Invocation, Anthony Lawrence P. Escovidal, MD. Philippine National Anthem. PMA Hymn. PUA Hymn. Welcome remarks, Rodrigo S. Hipol III, MD. PUA Mindanao Chapter President. Message from the PUA President, Harry G. Longno, MD.
COVID updates and lessons learned. Dr. Anthony C. Lechin, Hexen Pediatric Urology. Dr. Michael E. Chua, Hexen Male Infertility. Dr. Marlon P. Martinez, Hexen Urologic Oncology. Dr. Sigford Ian R. Alpajero, Hexen Telemedicine Practice. Dr. Iris Tili Isitan, Hexen Female Urology. Dr. Fidel Tomas III Manalese, Hexen Endourology. Dr. Mohammed Lesret.
PUA Mindanao Video Presentation. Closing Remarks. Manuel Gerard L. Sevilla MD. PUA Mindanao Chapter Vice President.
Lord Jesus, as we start this online postgrad course, we bring your presence with us. We speak your peace, your grace, and our perfect order into the atmosphere of this webinar. We acknowledge your Lordship over all that will be spoken, thought, decided, and accomplished within this online conference. Lord Jesus, we thank you for the gifts you have given to each and every one of us. We do not take them lightly, but commit in using them responsibly and well. Give us fresh supply of truth and beauty to which we draw our strength in doing our job. Anoint our creativity, our ideas, and energy so that even our smallest tasks may bring you honor. Lord, when we're confused, guide us. When we're weary, energize us. When we're burned out, infuse us in the light of your Holy Spirit. May the work that we do and the way we do bring the life and courage to all that we may in contact with. Lord Jesus, even in these days' most stressful moments, may we rest in you. In your strong and powerful name, we pray. Amen.
Bayang magiliw, perlas ng silanganan, alab ng puso, sa dibdib mo'y buhay. Lupang hinirang, duyan ka ng magiting, sa manlulupig, di ka pasisiil. Sa dagat at bundok, sa simoy at sa langit mong bughaw, may dilagang tula at awit sa paglayang minamahal. Ang kislap ng watawat mo'y tagumpay na nagniningning. Ang bituin at araw niya kailan pa may di magdidilim. Lupa ng araw ng walhati pagsinta, buhay ay langit sa piling mo. Aming ligaya na pag may mga api ang mamatay ng dahil sa'yo.
Puso ko'y tinig ng kasayahan, dahil ako'y nasama sa tanan. Ang lahat may gintong nasa, makisig at masigla. Kapisanan ay tunay ang damdamin, suliranin itong baya'y pawiin. Inalangin natin ang tapat sa may kapal, ay lunas sa lahat. Awit ng DNA, tayo ay mag-iwan. Magtulungan, pagunlad ng bayan. Ang kailangan, ibigay sa kanan, kalusugan at kasaganahan. Ang puso ko'y tigib ng kasayahan, dahil ako'y nasama sa tanan. Ang lahat may gintong nasa, makisig at masigla. Kapisanan ay tunay ang damdamin, suliranin itong baya'y pawiin. Inalangin natin ang tapat sa may kapal, may lunas sa lahat. Inalangin natin ang tapat sa may kapal, may lunas sa lahat.
Good morning. We would like to welcome everybody in the 15th Postgraduate course, also the first online of the Philippine Urological Association Mindanao chapter. This course is entitled Urology Practice Hacks. Hopefully, this particular postgrad would be the last online. Malaking sana. Traditionally, a specific city of Mindanao volunteers and the urologists in that place would exert all their charm and muscle to get the coveted honor of becoming the hosts of the annual postgraduate course of the chapter. For this year, it should have been in the province of Misamis Occidental, specifically in Ozamis City. Preparations started together with Dr. J.M. Feliciano. Unfortunately, this pandemic invaded our lives. We went into shock. We froze. We cried, caught flat-footed. Avalanche of questions linger in our minds. Paano na? Few weeks of waiting passed by. We observed and consulted. And finally, the PUA Mindanao chapter officers, with a heavy heart, decided to cancel the scheduled July 12 to 13, 2020 postgrad course. In lieu of this, we decided to have webinars. Despite all this, the members still verbalized their much desire of still having a postgrad for this year. Ang tanong ng lahat, posible at kaya ba? Fortunately, among the chapter members, I noticed that this person has the potential of fixing an online postgrad. We are grateful that Dr. Nimrod Firaza accepted the challenge to be the course director for this postgrad course. Sa wakas, ang postgrad ay hindi nagwawakas. We agreed on proceeding with this with or without any pharmaceutical support, since the main purpose is to have a means and arena where we can bring out and exchange new medical ideas in general and urological in particular. Postgrad course without pharmaceutical partners may not be okay, but sometimes it's okay to not be okay. But fortunately, despite all the physical distancing, no face-to-face interactions, and closed clinics, we were able to win a pharmaceutical company to be our exclusive partner for this postgrad. We are very grateful with ECE Marketing Company. The chapter members will never forget this. Salamat po sa inyong suporta. So, we may not be able to meet you now, have face-to-face interaction, shake hands, entertain and welcome you physically, but we are very much excited and eager to welcome you virtually. I don't like to make these opening remarks long. May I request everyone to relax, listen, get a drink, and crash land on your seats and enjoy staying with us today. With the powers vested upon me as the President of the Philippine Urological Association Mindanao chapter, I declare this 15th and first online postgraduate course officially open.
Greetings. It is my privilege and pleasure on behalf of the Philippine Urological Association to welcome you to the 15th postgraduate course of the Philippine Urological Association Mindanao chapter. We are delighted to have you with us to participate and exchange knowledge in this virtual postgraduate course. The PUA Mindanao chapter is committed to continue spreading the craft of urology in Mindanao, and we still continue to do so given that we cannot hold it through physical means amidst this pandemic. Our task is to make it possible. Our mission is to help non-urologists with practical step-by-step and clear-cut assistance in dealing with urology cases. The PUA Mindanao chapter is the first chapter of the PUA and has been at the forefront of several PUA activities. The results speak for themselves as they host this postgraduate course for the 15th time. I am honored and proud to have seen and been a part of the growth and progress of the chapter. Prepare yourself to be challenged, excited, and inspired. Mabuhay ang PUA Mindanao chapter.
This speaker floods himself with noteworthy achievements leading Philippines' preventive health education and health reform advocate. Graduated among the top students of his class from University of Santo Tomas College of Medicine to the time he placed among the top notchers of the medical licensure exam to become most outstanding resident in internal medicine at the Manila Doctors Hospital and serve as the chief resident in his senior year. Continued his fellowship in cardiology at the UPPGH Medical Center and likewise awarded as the most outstanding research fellow and also served as a chief fellow in his senior year. Remained humble yet with tenacious disposition, he became one of the leading cardiologists in the Manila region. He was the medical director of Unilever, Philippines from 1993 to 1995, and later as medical and regulatory affairs director to Pfizer Philippines from 1995 to 2010. Over the next 2 decades, his enterprise expanded beyond the practice of medicine. His portfolio came to cover, among all things, public service. He served as Director of Information, Publication, and Public Affairs of the University of the Philippines, Manila, from June 2012 to October 2014. He was later elected Fellow of the American College of Physicians 2014 and recognized as well by distinguished medical societies in Asia as a honorary fellow of the Royal College of Malaysia in 2014 and Thailand in 2014. He was later elected president of the UST Medical Alumni Association for the years 2015 and 2016. But perhaps his greatest achievement remains to be Executive Order 595, the Health Education Reform Order, or HERO, an initiative he authored as chair of the Advocacy Committee of the Philippine College of Physicians in 2007, a 10,000-member strong organization of internal medicine specialists in the country, which he later headed as president from 2014 to 2015. His HERO program remains to be the largest Philippine-led advocacy on comprehensive health education and disease prevention today. For leading and pioneering the passage of a significant executive order, he received a presidential citation from President Gloria Macapagal Arroyo in December 2007 for helping the government with its preventive health education advocacy. In 2012, he was the lead proponent of the civil society while working as a 1 peso consultant of the Department of Health on non-communicable disease in the passage of Landmark 6th Sin Tax Reform Law for tobacco and alcohol signed last December 2012 after languishing in Congress for 16 years. This pioneering mark promises to curb smoking and alcohol illness and is expected to continue an additional 200 billion in tax revenues for the government. He will probably go down in history as one of the most bemedaled Filipino physicians of his generation. He continued solid civic-spirited goals, being active in promoting social and community causes. From January 2016 to March 2019, he served the Philippine Health Board of Directors as an independent director, monetary board representative, and actively participated in various board committees from audit, risk management, benefit, investment, governance, and a host of others. Apart from his active participation in the different field health committees, he was a vital cog in the passage of Universal Health Care Law alongside the Department of Health and field health colleagues. He is a passionate leading proponent of the medical community and other stakeholders from the public and private sector in raising additional taxes for tobacco and alcohol to sustainably fund the landmark Universal Health Care Law recently signed by President Rodrigo R. Duterte. Furthermore, on January 8, 2020, the UST MAA, together with Tomas Awards Committee, once again recognized his contribution not only to the medical community, but to the public health as well, and granted him the 2020 Tomas Award in Public Health and Health-related issues. In light of recent events, the Philippine government has seen the need to utilize his expertise through the use of his valuable inputs in responding to the COVID-19 outbreak in the country. On April 1, 2020, he was tasked to serve as special advisor to the National Action Plan COVID-19, chief implementer whose main function is to provide medical expertise to the National Task Force on COVID-19. Indeed, a thick profile and accomplishment of his lifetime, he will forever be respected and remembered. Let us welcome Dr. Anthony C. Liachon.
Good morning. I'm Dr. Tony Liachon. I'm a health reform advocate. And my task for today is to discuss to you the COVID epidemic and what lessons have we learned after 6 months. I'd like to begin the discussion on the definition of flattening the curve. What are the global and current local data that we have? What reference models have we used? And what are the 4 pillars to reopen the economy? Are the vaccines the silver lining? And why do we fail in health and other initiatives? Flattening of the curve would mean that there are usually 2 curves that we need to understand. One, here in the y-axis or the vertical axis would be the number of cases, and the horizontal would be the time since the first case. The higher the curve would mean higher acceleration, and then there will be peaking and then deceleration if we will not do any protective measures. Our goal is to have a slower acceleration by actually doing some protective measures and then with gradual deceleration. This is done specifically so that our healthcare system capacity will not be overwhelmed. Thus, the higher the curve, it means higher acceleration. And of course, the greater will be the damage to that particular locality. Now, what if your loved one is this part of the curve and you have here strict lockdown of cases? Our goal is basically to increase our healthcare capacity at this point in time. Now, with more time, we will buy more ventilators and open respiratory isolation wards. That will also give us time to stockpile PPE and other medical supplies. That also will give us time to integrate telemedicine and do massive testings of our patients as well as contact tracings, and then train the healthcare workers in order to address the hospitalized patients. And then we need to do a lot of workshops and learn from other colleagues and find the bright spots in the hot spots in other areas of the country. The current data would show that the number 1 country in the world with the most cases is the United States of America, with 6 million cases and 186 deaths. But USA is actually on the deceleration phase, is on flattening the curve at this point in time. On second spot is actually Brazil, with 3.8 million cases and 121,000 deaths. On third spot would be India. India is right now on an acceleration phase with 3.6 million cases and 64,000 deaths. The Philippines has the longest containment period in the world. And right now we're entering our 6th month with the different milestones and the different initiatives. What would be our comparison with the rest of the Southeast Asia. We're the number one country right now in terms of cases in the Southeast Asia, followed by Indonesia, and then followed by Singapore. Comparing the country with the different countries in Southeast Asia, you can see here Cambodia, starting off in March, but Cambodia's flattened the curve. And this is the curve of the Philippines. You see here from January to February with a little plateauing, but because of the Cebu surge and the surge in the National Capital Region, then we have a stepladder epidemic curve. Malaysia has also flattened the curve vis-a-vis the Philippines. And then you have Myanmar. Myanmar has also flattened the curve versus the Philippine epidemic curve. There are only two countries in Asia which have not have flattened the curve, and that is the Philippines and Indonesia. In this next slide, you will see that Singapore has a unique curve. After controlling the situation, you have here peaking and then deceleration. When they opened the borders to migrant worker, there was a surge, but they were able to control it, leading to a deceleration. And here is the Philippine epidemic curve. Vietnam is one of the best reference models in the world, and they were able to flatten the curve with almost zero mortality, except for some reopening of the borders leading to about 10 deaths. But Vietnam has been considered one of the best reference models in terms of flattening the curve. Thailand is another good reference model. They have flattened the curve when they started in February. They flattened the curve sometime in March. This is the current situation in the Philippines right now, with a few index cases. On February 29, we had only 3 cases, and then in March, 2,000 cases. April, we had 8,000 cases. May, 18,000. June, 37,000. And July, we had only 31,000. But our situation actually worsened this particular time when we had an increase in the cases in the Philippines to about 220,000 cases. So as you can see, if you will add up everything here, the sum of all the cases from February to July would be around 90,000. But here, just in July, you can see that we actually had more than 100,000 cases. And August is really a bad month for us. And this is actually seen in this particular chart. Now, we have also 4,000 cases on the average daily on the month of March. And you can see here, based on our projection, that we might actually be reaching more in the next few weeks, unless we can radically implement the healthcare capacities to be in place, that is testing, contact tracing, and isolation and quarantine. In July, the critical care capacity of the different hospitals was reached. And up to this point in time, we have problems regarding the capacity, the bed capacity, the ICU, and the mechanical ventilators of the different hospitals. Now, this one is a nice slide showing us here that when Cebu City was in crisis sometime in mid-June, the IATF mandated ECQ for almost 4 weeks and then MECQ for 2 weeks, you see here a gradual reduction of the ICU bed occupancy rate. And in contrast with the National Capital Region, during the time when there was a surge in Cebu, there has been a gradual increase in the ICU bed occupancy rate together with the contiguous area that is in Region 4. Now, since we have not seen a pandemic in our lifetime, when I was PCP president in 2015, I was able to review the Ebola experience. And based on the template, the first one that we need to understand is we need to slow down the virus. We need to take swift action to temporarily ban public gatherings, close schools, and ask the residents to stay at home. They were able to prevent the viral spread from the rural to the urban area. And since we are dealing with an invisible enemy, massive testing should be done, rapidly scaling up testing, and bring it as close as possible to the residents' homes. And it's just like looking for a needle in the haystack with your eyes closed, so that it is really an imperative to do massive testings, about 3 to 10% of the population. We need to understand that we need to protect the healthcare workers at all costs, who will provide care for the sick, and then repurpose the arms of the government, and that is the uniformed personnel, to support the epidemic response, to urgently deliver PPEs and other medical supplies. Once all the health measures have been undertaken, that is the plan right now for the economy to open. Now, there are two good countries that we can use as reference models, and that's basically Vietnam and New Zealand. And basically, they were successful because of the following reasons. They had quick, coordinated response. Nationwide lockdowns were done, but they were only very short. In fact, Vietnam had only 21 days of lockdown. There was massive and meticulous contact tracing. There was a strict enforcement and restrictions in movement done by uniformed personnel. And lastly, but I think the most important, they exhibited exceptional leadership and governance in times of crisis. South Korea has been a favorite reference model of mine. Without the benefit of the lockdown, they intervened quickly before it was too late. They actually installed or established the touch testing center. They tested early, often, and then safely. And then they established contact tracing, plus isolation facilities, quarantine facilities, and did surveillance studies, and used also digital technology to actually do contact tracing. And lastly, and I think one of the most important things that we need to understand, that in terms of doing crisis management, enlisting public health, that is recruitment of medical experts, epidemiologists, data analytics, and the business sector would be a great help in order to address the crisis. When I was a member of the National Task Force, on my third day, I presented this particular concept, the hammer and dance concept. This was published by well-known social writer Thomas Pueyo. And it's basically about suppression versus mitigation versus doing nothing. If you will do nothing, you will have a steep curve. But when we do mitigation, we will actually do suppression or mitigation, and of course, reduction of the cases. Now, you need to understand that during this particular lockdown, you need to do massive public health education. You cut down the virus growth, understand the cases, recruit a lot of personnel, and improve all the treatment options and get the proper testing and tracing, basically to put the healthcare capacity in place during this time. Now, it would last from 3 to 7 weeks. Now, once you are on the deceleration phase, and once the R naught is less than 1, then you can actually dance with the economy. And this is the hammer and dance concept. But we need to be resilient as well as relentless in trying to maintain the healthcare capacity during this time as we reopen the economy, because we want to prevent a second wave or a surge because of mobility. So we need to understand the basic guidelines during the reopening of the economy. Perhaps you need to understand the definition of the area classification and the quarantine and the different intervention. When we mean ECQ, that is Enhanced Community Quarantine, it means no movement regardless of age and health status, minimal economic activity except for utility services, food, power, water, and of course, the critical economic sector. No transportation except for utility services, and suspension of classes is a mandate. Now, when you mean modified ECQ, you have limited movement within the zone, plus operation of selected manufacturing and processing plants up to 50%. And then you have limited transport services for essential services and goods. Again, there will be suspension of classes. When you mean GCQ, or General Community Quarantine, it means limited movement to services. And the operation of government and industries will be up to a maximum 75%. There will be opening of public transport, and this will actually cause some problems in terms of surges because of the social distancing measure that will be actually be negated at this point in time. And then the DepEd will actually implement flexible learning arrangement and will be operating on a modular basis. And then the modified GCQ, you have permissive socio-economic activities with minimum public health standards. We have a plan actually, but I don't think it has been properly articulated by the government. We need to continuously inform the public. When we inform the public, we will be able to influence and inspire people. We need to do a massive preventive health education campaign. We need to do a lot of tracing. We need to do RT-PCR and all of these things per LGU. We need to construct a lot of isolation facilities. And then we need also to understand that we need to support also the healthcare workers in the hospitals. Once all of these measures are done, or management system done, then we will be able to reintegrate the society and then transition them into the new normal. The government last month appointed 4 leaders or SARs. Dr. Vince Dison, the testing SAR. You have Mayor Benji Magalong from Baguio City, a former intelligence chief of the Philippine National Police, the contact tracing SAR, the hero of the Cebu City success. You have Secretary Mark Villar, the isolation facility czar, and then the very diligent and very reliable Undersecretary Leopoldo Vega from Mindanao. He is the current treatment czar of the National Task Force. Now, during the time of the first surge in January, February, the government tested only those with strong symptoms, those particularly the healthcare workers and those working in crowded places. But right now, the mandate is to test everybody and test everybody every week so that we'll be able to understand the magnitude of the problem. And we need to understand that we cannot flatten the curve unless the 4 pillars to control COVID crisis are in place. We need to test. We need to ask the question, who is infected? We need to trace who are those in contact with the infected person. We need to isolate. We need to prevent those infected from transmitting the disease. And lastly, we need to quarantine, prevent the contacts from infecting others. These are the essential 4 pillars in order to flatten the curve. And the other countries in Southeast Asia which have flattened the curve are actually have perfected these particular initiatives. Now, of course, you heard about the University of the Philippines Octa Research Team led by Professor Guido David and Professor Ranjit Singh of the University of the Philippines. These are the latest data that was actually forwarded to the Interagency Task Force and the National Task Force so they could come up with new quarantine guidelines. The R0 or R0 is a mathematical term that indicates how contagious an infectious disease is. And RO tells the average number of people who will contract a contagious disease from an infected person. Thus, if R0 is less than 1, each existing infection causes less than 1 infection. And in this case, the disease will decline and eventually die out. When we mean R0 would equal to 1, each existing infection causes only 1 new infection. The disease will stay alive and be stable, but there won't be an outbreak or an epidemic. And lastly, if R0 is more than 1, each existing infection causes more than 1 infection, and the disease will be transmitted between people, and there may be an outbreak or an epidemic. We need to understand this particular concept so that we will be able to advise the IATF and of course the other agency and the whole citizenry. The Philippines has a reproductive number at this point that is almost 1. From 1.49 last July 16 to 22, it has gone down to 1.03. The Philippines number of new cases per day has decreased from 4,300 August 12 to 18. And because of the MECQ, the cases have been slightly reduced, and perhaps this is secondary to the gains of the MECQ. The projections for September 30, if we will use the GCQ, then we will have a lower projection of 330,000, a median projection of 350,000, and of course a higher projection of 375,000, just in case the healthcare capacities will not be in place and the social distancing guidelines will not be followed by the people. The National Capital Region is the heart of the country. It has around 12% of the country's population, basically about 12 billion, and contributes to about a third of the annual gross domestic product. And thus it is the epicenter of the country's pandemic, contributing 55 to 60% of the total number of cases to date. The daily cases in the National Capital Region, because of the MECQ, has gone down from 2,684 to 2,192. And the R0 has decreased below 1. And this has been because of the implementation of the MECQ. But we're not yet out of the woods yet, and we should not declare victory too soon. The NCR positivity rate decreased to 14%. The WHO benchmark is less than 5%. There's still transmission, local transmission, and we need to work harder to reduce the positivity rate to around 5%. The hospital ICU occupancy in the National Capital Region, as you can see here, 9 LGUs are at critical level, and these are the city of Muntinlupa, Marikina, Valenzuela, Taguig City, Las Piñas, the city of Mandaluyong, Quezon City, the city of Makati. And then those who are doing well at this point in time, less than 70%. City of Pasig, Pateros, Pasay City, Caloocan, and then Parañaque. The projections for the National Capital Region, we hope that we can actually have only 180,000 by the end of the month, because this would cause some problems in our economy, particularly our GDP. Now, is the vaccine the silver lining? For disclosure, I was past medical director of Pfizer. I worked for Pfizer from 1993 to 2010. And one of the products that we've launched is actually a vaccine, that is a Prevenar. So I have extensive pharmaceutical and regulatory affairs experience in this aspect. Now, of course, we know that we need to do clinical trials. We need to do phase 1, phase 2, and phase 3. And some of the products that we have right now are on phase 3 and they're on track. And these are AstraZeneca, you have Moderna, you have Pfizer Biotech that is from Germany, and 3 Chinese compounds. Now, this will have facilitated US FDA approval, and hopefully they will be approved sometime in December so that they can be launched during the first quarter of next year and be given in the second quarter to a lot of people in the Philippines. According to the WHO list, on August 13, there are 29 vaccines in the clinical evaluation stage, where at least phase 1 clinical trials have begun. Now, out of this, the following 6 candidates are actually on track for phase 3. The University of Oxford AstraZeneca from the UK, the vaccine co-developed by Moderna and the National Institute of Allergy and Infectious Disease in the United States, Pfizer Biotech from the US, and 4 vaccines coming from China. The Chinese vaccine maker Sinovac, the Wuhan Institute, and the Beijing Institute in China. Now, according to the Department of Science and Technology, the COVID-19 vaccine would likely be available by the second quarter of 2021. And the clinical trials in the Philippines will be starting fourth quarter of this year, sometime in October. Now, if the results are good, the local FDA will review it for approval, then the public will have access to it by the second quarter of 2021. But vaccines are not silver bullets. We need to understand that healthcare capacity should be enhanced and should be in place. That is testing, isolation, contact tracings, and quarantine. And this will be our future for at least in the next 2 or 3 years. Now, the reasons why we fail in health and other endeavors, I'd like you to read this particular book by Dr. Atul Gawande, a cardiothoracic surgeon from Harvard. And he said that these are the following reasons why we fail in health and in other endeavors. The first is ignorance. So education is key. And then ineptitude. Knowledge is there, but we fail to comply correctly. Lack of blueprint for change. And then leadership and governance problems. In one particular article by famous columnist Bu Chanko, he said that LGUs will be very important to the healthcare system. In the face of the national government's failure to have an adequate COVID-2019 response, a number of LGUs have stepped up to the plate. And these are Marikina Mayor Marcy Chodoro, Valenzuela Mayor Rex Gatchalian, Mayor Vico Soto, Mayor Isko Moreno, some other governors, and of course, Baguio City's Mayor Benji Magalong pretty much kept the city COVID-free for a long time, and he's right now the contact czar of the Philippines. Now, according to former Secretary of Health, Dr. Manolet Dairit, now former dean also of the Ateneo Graduate School of Business, he pointed out that the role of LGUs cannot be overemphasized in managing the epidemic. He would actually place the responsibility on the LGUs, and we need to understand that also moving forward, the local government unit will be at the forefront of enforcing social distancing rules, wearing face masks and face shields, and monitoring the health conditions in the densely populated communities, particularly in the national capital region. And this emergency will most likely occupy their attention even beyond 2022. Now, another book that I'd like to read is The Switch. It's a classic book on how to change things when change is hard by the Heath brothers. Basically, we need to have a good leader that we can direct, who will follow the bright spots, the best practices in the Philippines or other areas or other countries in Southeast Asia. A good leader or a rider that is actually script the critical moves and point to the destination. This particular rider or leader should be able to motivate the elephant. The elephant is actually the population, the people. We need to find the feeling to inspire and motivate the elephant. We need to shrink the changes. We need to understand that we need to grow people as well. They should not be blamed for all these problems, because I think we need to do a lot of campaign in terms of messaging. Very important that we need to connect to the public. But we need to have a blueprint. The rider or the leader and the elephant or the population will only walk in if there's a path being directed to them. Then we need to tweak the environment and build healthy habits. And we need to constantly rally the herd and motivate the elephant so that we can actually control the viral transmission. Of course, it is important to understand that an ounce of prevention is better than a pound of cure. And based on the study of Dance et al. This year, face mask and face shield would have a 93% reduction, risk reduction. 1 meter distance plus face mask, 94% reduction. 2 meters distance plus face mask would result in 97% estimated risk reduction. And 1 meter at least face mask and face shield will lead to 99% risk reduction of contracting COVID-19. So ladies and gentlemen, this is very important. And perhaps we need to embrace this particular advocacy so that we can actually rally the herd and motivate the people. And we need to step up to the plate to help our government at this point in time. So we need also the doctors to step up. We need to inspire the civil society. The word doctors comes from the Latin word docere, which means to teach. So we need to teach. We need to tell people that we can control the viral transmission. We need to heal, and we need to lead our leaders as well. As doctors, we need to recognize the problem. There's a huge elephant in the room right now. But sometimes we tend to ignore that huge elephant. And we need to understand that the economy will never recover as long as the virus is not controlled. And if we don't understand it, then we are part of the problem. Is the money the solution? An important metaphor is that the country is in the ICU. Now, do we need to transfer a patient to the regular room instead of retaining the patient in the ICU because we don't have much funds? I think we need to find the cure to our problems, like testing, isolation, contact tracing, and quarantine, and then find a way of funding that particular cure. And this is the only way that we can reopen our economy. So this is the 12-point long-term plan for COVID-19 by the National Task Force. And based on the WHO criteria, these are the measures that should be done. We need to understand that before we lift the quarantine, viral transmission is controlled. The health system capacities are in place to detect, test, isolate, and treat every case and every contact. Outbreak risks are minimized in health facilities and nursing homes. Preventive measures are in place in workplaces and in schools. Importation risk can be managed, the OFWs and overseas Filipinos. And then we need to fully educate, engage, and empower to adjust the Filipino to the new normal system. We need to do a lot of massive testing, targeted and focused, to diagnose both the sick and the healthy. We need to establish isolation and quarantine facilities in the local government unit. And then we need to create COVID hospitals in each of the locality so that we'll be able to admit patients who are also non-COVID. We need to manage the overseas contract workers to prevent the second wave of infection and prepare for the rainy season from June to December, because we know that we are being battered by typhoons 22 times a year. And this will also be the time then we will have a lot of dengue, flu, and of course pneumonia. We need to enlist the best and the brightest health leaders, academicians, advocates in the entire medical community. We need to partner with the business sector. We need to prepare the country to transition to the new normal, to a strategic communication plan. And we need to generate real-time and more granular data with zero backlogs and rapid turnaround time. And we need also a monitoring and evaluation system with a clear metric of success. So ladies and gentlemen, there you have it. I'm very hopeful that we can flatten the curve in the next 100 days. But we need to step up. We need to model the way. We need to inspire a shared vision. We need to challenge the process, and we need to enable others to act and encourage the heart and motivate the people. I'd like to quote in closing Dumbledore from the Harry Potter movie. Happiness can be found even in the darkest of times if one only remembers to turn on the light. Thank you very much for your kind attention. Thank you very much.
Our very next speaker is a cavalier in the field of urology. This man has already a ton of his list in his accomplishment, awards, and publications before his golden years. Graduated his medical course in St. Luke's College of Medicine, where he pursued residency in urology in the same institution. During his training, he received several awards. First place, St. Luke's Medical Center Patient Safety and Quality Week Presentation. First place, St. Luke's Surgical Research Forum Contest. First place, Philippine College of Surgeons Champion of Champions. Champion in Philippine National Urology Case Paper Presentation, not to mention the second and thirds that he received. He graduated his residency and passed the Philippine Board of Urology certifying exam with an exclamation mark ranking number 1 last 2015. He proceeded fellowship training in urodynamics and pediatric lower urinary tract dysfunction in Buddhist Chu Chi General Hospital, New Taipei Branch, Taiwan. In 2015 to 2017, he underwent pediatric urology clinical fellowship at the Hospital for Sick Children in University of Toronto, Canada. In the next 2 years, he finished his adult and pediatric genitourinary reconstructive surgery clinical fellowship in Eastern Virginia Medical School, Centara Norfolk General Hospital, Virginia, USA. In 2018, he topped the Philippine Society of Pediatric Urology membership certifying exam. He also underwent different trainings: Da Vinci robot surgical training, Surgeon Console program, Harvard Medical School, advanced laparoscopic training course in National Taiwan University Hospital and Andrology in Fertility, transitional urology in reconstructive surgery observership in University College of London Hospital, London, United Kingdom. Currently, he is a urology specialist consultant in St. Luke's Medical Center, Quezon City, and an active mentor in research supervision for the urology residents. He has long lists of co-authored journals and book chapters. To mention a few are handbook series of consent in pediatric surgical subspecialties in pediatric urology, endourology progress, technique, technology, and training, principles of urethral reconstruction, and its instrumentation in textbook of male genitourinary reconstruction. All those colors in the rainbow will always be in his sky. This cavalier in urology will also be a source of wisdom. I am honored to present our next speaker, Dr. Michael Chua.
Hi, good afternoon. Thank you for inviting me to the Philippine Urological Association Mindanao Chapter Postgraduate course for year 2020. I'm Dr. Michael Chua, currently having additional training at the Hospital for Sick Children, or Sick Kids, Toronto, Canada. At the same time, I'm an affiliate consultant at the St. Luke's Medical Center, Philippines. Let's start with the objective of this session. Foremost, we'll be discussing a brief overview of the etiology and classification of hypospadias. Secondly, we'll discuss contemporary management of hypospadias. And lastly, we'll be reviewing the current literature on the surgical outcomes of hypospadias repair, as well as the recent guidelines and recommendations. For the disclosure, I have nothing to disclose. Let's start with the hypospadias component. So in most cases, hypospadias is associated with three anomalies, namely a ventral meatus that may be located anywhere between the glans and the perineum. Secondly, a ventral deviation of the penis, or commonly known as chordate. And lastly, the dorsal prepuce hood in association with a ventral deficit of prepuce. Please take note that the second and the third abnormalities are not necessary for diagnosis of hypospadias, although they are commonly present with severe hypospadias. Going to the embryology of hypospadias development, it is when the congenital defect occur when there is the urethral development between 8th and 20th gestation, particularly when there is arrest of urethral development, and this mainly due to the testosterone influence or stimulation affecting the masculine phenotype. Typically, it is due to an open groove or open urethral groove extend from its base up to the level of corona, and arrest then would dictate the severity of the hypospadias. What are the hypospadias incidence and prevalence? According to studies, it varies from 0.3 to 0.7% in live male births. The incidence varies with ethnicity, more prevalent among the Caucasian, next Blacks, and Hispanic in origin. Currently, there are numerous studies that show there is an increasing prevalence worldwide, and this map will show you a longitudinal study from 1910 to 2013. The median study period was 9 years, ranging from 1 to 36 years, and the most prevalent is among the North America and Europe. And there is a wide range between the Asian and African region. Now we'll be talking about the risk factor of hypospadias. In most cases, hypospadias, the cause is unknown. However, there are reported risk factors, including the following. Pre-existing maternal disease, such as diabetic mellitus or DM type 2, it is due to endocrine factors, and advanced maternal age, which they are the high-risk group. Prematurity, particularly when born before 37 weeks of gestation, due to fetal growth restriction or other reasons. History of paternal hypospadias will increase their offspring of 8%, and a male sibling with hypospadias, particularly a severe type, have a 14% incidence. Exposure to chemicals, especially nowadays, we have a lot of estrogenic food, and these are considered the environmental factors. Placental insufficiency, such as low placental weight and pathology, can cause fetal growth restriction, which previously mentioned earlier. And in modern society, there's increased use of in vitro fertilization, and it may cause maternal progesterone exposure. It increase 5 times the risk of having hypospadias. So now we'll be applying some clinical applicability. So in the description, this is commonly required to describe the hypospadias characteristic. Number 1, we need to describe first the position of the meatus, which we'll detail later. The shape, whether it's a fish mouth, and also the urethral plate, the width of the orifice or the urethral plate, the description of the urethra, particularly if there's an atretic characteristic or division of the corpus spongiosum. The appearance of the prepucial hood and scrotum, particularly if there is tethering. Penile size is important, thus at this moment, we also measure the penile size intraoperatively to make sure we're able to document everything. And most importantly is the curvature of the penis on erection. Hence, after degloving the penis, we would do an artificial erection to determine the actual curvature. Lastly is the position of testicle. Please take note, every time whenever a patient referred to your office with an hypospadias, you need to assess the testicle to make sure they're both descended. And I'll explain later why. So let's start with the description of the curvature. So ventral curvature of the penis is often associated with hypospadias, especially the more severe forms. It is due to growth disparity between the normal dorsal tissue of the corporal bodies and the attenuated ventral urethra. Sometimes it is also caused by an abortive spongiosal tissue and fascial distal to the urethral meatus, which forms a tethering fibrous band that contributes to the ventral curvature. So we classify the curvature according to severity. So if it is no curvature to 15 degrees, they are considered normal. However, if there's 15 to 30 degrees, they are considered mild. And this kind of curvature can actually be addressed with dorsal plication, which I'll discuss later as well. For moderate degree of curvature, which means more than 30 degrees, or severe, where it's even more than 80 degrees, then there are the severe type, and dorsal plication is likely not able to correct this kind of curvature. And commonly in our institution at CKIDS right now, we usually do urethral transection, plan for 2-stage hypospadias repair, or even we need to do ventral corporotomies, which I'll discuss later as well. Next is a description of the location. So at this point, there is a widely 3 classification, particularly anterior or distal, subclassification as the glandular, coronal, or subcoronal, mid-shaft, which include the distal penile, mid-shaft, and proximal penile, or the posterior or proximal hypospadias, including penoscrotal, scrotal, and perineal. The incidence, according to Western literature, the anterior is approximately 50% of the case, mid-shaft is around 20%, and posterior is around 30%. and subcoronal position is the most common overall. So here's a simple graph where the history of different kind of description before, and it is until 1996 where Dr. Dackett finally classified the big category into anterior, middle, and posterior, which is currently we use as distal, mid-shaft, and proximal. The images below this slide will show you the representative description of the position of the meatal opening. So again, this is a sample where we would describe the meatal opening, and it's important to do an intraoperative description as well. As you can see on the image on the left side, when you put in a catheter and there is a membrane, you cannot say the meatal opening is on the subcoronal in this case, or in the distal penile, because the membrane that you can see through the lines in the urethra or the catheter actually is not a healthy tissue, and you need to cut down before doing the repair or degloving. Likewise, if you don't do your stitches or the stay suture, it will be difficult for you to actually see the urethral opening, as you can see on the right side images. Again, if you put a stay suture on the glans penis, that will enable you to have a quick look on the actual opening. And this is a sample of a severe type or a proximal hypospadias with the opening almost in the scrotum. So again, what are other associated syndrome? So the most common associated syndrome is cryptorchidism. Hence, it is important once you encounter a patient with hypospadias, make sure you're able to palpate both testicle, because there's 20% undescended testicle among severe hypospadias. There is around 16% with inguinal hernia or hydrocele or open processus vaginalis. At the same time, patient with disorder of sexual development, there's 30% having hypospadias. And there is a relationship between severity of hypospadias and associated anomalies of upper or lower urinary tract. Hence, with level of evidence 3, if you're considering multi-organ anomaly, a renal ultrasound with urinary bladder is recommended. Particularly according to the EAU guideline in evaluation for hypospadias with cryptorchidism, further indication to rule out DSD is important. Hence, this patient need to be referred for complete genetic or karyotyping and endocrine workup to rule out congenital adrenal hyperplasia. And the grade of evidence or the recommendation is A, and it is important, especially for the trainees to understand this. So now we'll be moving on the surgical indication and approach of hypospadias repair. So the most important surgical indication or management is the functional indication. Particularly, there are 3 factors that have a strong indication that we need to do certain repair for the patient. Number 1, if the location of the urethra is very proximal, then it will cause ventral deflected urinary stream, and sometimes it is associated with meatal stenosis. Next is a severely curved penis, which also would deflect the urine stream. Hence, your indication is if the patients start having significant deflection of urinary stream, or you consider due to severe curvature or the proximal location of urethra, won't enable the patient to urinate from a standing position. Likewise, if the curvature is so severe, it will lead to difficulty of intercourse or even fertility issue due to a difficulty of sperm deposition to their partners. This is an example of a very mild hypospadias. Actually, the opening is in the corona. The leftmost image is a representation image of a baby with coronal hypospadias, and the subsequent images are the same image from the same patient where they're at their 16th year of age, and it's more of a cosmetic issue rather than a functional issue, because this patient is able to pee and there's not much of a curvature noted. So the next indication is more of a cosmetic, and basically people will say it is something that may affect the psychological well-being of the patient or even the parents themselves due to abnormally located meatus, cleft glands, rotated penis, or abnormal looking prepuce or foreskin. Some adults experience no difficulty with such kind of appearance, particularly the mild hypospadias. However, the coronally located or distal penile meatus may generally dissatisfy this patient. Indication must be critically discussed with parents for a cosmetic indication to include explanation of possible complications, which the complications will be discussed earlier towards the end of this discussion. So now let's move on. What is the best timing to do hypospadias repair? So according to American Academy of Pediatrics, they recommend any elective surgery for the external male genitalia should be performed with individuals around age 6 to 12 month old, particularly this for the anesthetic indication. However, they also recommend the surgery needs to be completed between 15th and 18th month of life for the psychological window, particularly before age 3, to avoid a phallic stage of the psychological development. Although adolescents that have their surgery done before 2 years of age did not recall the surgery and more likely to have a positive image. And at the same time, we would recommend doing any kind of hypospadias or penile surgery before the patient is toilet trained. Some studies even suggest that initial hypospadias repair at a later stage in life could associate with more postoperative complications. So we'll be moving on with the techniques, and to date there is approximately 400 techniques and their modifications, and there's no ideal universal technique. However, the most popular one is the tears and duplay. Mainly it is just the tubulization or urethroplasty with preservation of urethral plate. There are other techniques in the early 1990s and late 1980s where they used the prepuce for urethroplasty. And for the proximal hypospadias, two-stage repair, currently known as the Brackett's two-stage procedure using buccal graft, is also well known. And in 1994, where Dr. Snodgrass had introduced the tubulized incised plate. And later in 1995, Dr. Dackett established the term hypospadiology, which I think hypospadias repair is a separate discipline that everyone needs to seriously thinking about etiology and management. What is the general principle of a hypospadias repair? And I will be discussing step by step, and they are ranked according to importance. So number one is orthoplasty or penile strengthening. As again, I've been reiterating that the curvature is very important in terms of indication and the success of the procedure. Next is urethroplasty. You will be doing a neourethra and make sure you have a wide caliber. Next is glandsplasty to make sure you're able to oppose the glans penis, and meatoplasty to make sure you're able to do a slit-like opening for a cosmetically appealing appearance, not a fish mouth or a subcoronal opening. Scrotoplasty is less important, particularly it is important only if you are noticing a patient with penoscrotal transposition, and commonly this is being done on a later stage. And making sure that you have enough coverage with circumcision or preputial reconstruction. All this step can be performed in a single operation or stage depending on the curvature. And the technique should be tailored to each individual case, mainly based on the curvature and quality of the urethral plate, which we'll expound later. So I'll be giving you a quick summary about classification, the frequency, the location of the urethra, penile curvature, foreskin appearance, and the recommendation of management at this point. So for very mild hypospadias with incomplete or partial presence of hypospadias, there's only 10%. The urethral location is pretty normal or in the glands and no curvature, and there's mild to asymmetric ventral deficiency. This patient doesn't need surgical intervention or any further evaluation. Next, which is the more common ones, having around 40 or 25% frequency for the distal urethral location on the glans or coronal margin, sometimes associated with mild curvature with ventral deficiency. Surgical correction in most cases, however, family may choose to observe. No further evaluations are needed. And for the more proximal urethral location of penile shaft or penoscrotal junction or within the scrotum with moderate curvature, definitely this patient needs surgical correction, particularly with functional indication. No further evaluation are needed in this patient. With severe abnormality of a small glans, less than 40 millimeter, The opening could be on the scrotum or perineum with an abnormally small glands with severe curvature, and obviously with tethering on the ventral part of the foreskin. Surgical correction are required and usually done in two-stage. Endocrine evaluation is needed to rule out disorder of sexual development. Other variants are mild, such as chordy or ventral curvature with no hypospadias. The urethral opening is normal at the gland or orthotopic with mild to severe curvature but normal foreskin. Surgical correction of the ventral curvature would be indicated if the urine stream is deflected towards the patient himself. Megameatus intact prepuce, mainly it's a large meatal opening at the coronal margin with no curvature and normal foreskin. Correction is usually performed based on family preference or later in life when the patient opens. So here's a quick algorithm published by Dr. Braga from McMaster. You can see the algorithm on the left side. If a patient with proximal hypospadias, you had a residual curvature after penile degloving down to the vulvar urethra, depending on the curvature. If it's less than 30, again, as I mentioned earlier, dorsal plication are acceptable. I will discuss a quick approach later. However, if it's more than 30° or even worse, more than 70°, then urethral transection is indicated. And then you reassess after the urethral transection whether the curvature have improved. If it's less than 30°, you can do additional dorsal plication. If it's more than 30°, then multiple ungrafted ventral corporotomies are indicated. So what is ventral corporotomy? It is mainly doing a 3 deep cut on the tunica albuginea of the corporal bodies, and to make sure you are able to do it on the maximal curvature and straighten the corporal by doing so. Again, on the algorithm on the right side, these are the patient with proximal hypospadias with no significant curvature. However, it is being assessed depending on the urethral plate characteristic. If the urethral plate is wide and elastic, then you can proceed with proximally trivialized incised plate repair. However, if it is narrow, then you need to transect the urethral plate and think about doing a graft. If unfortunately patient was referred to you post-circumcision, then likely you will need a buccal graft and proceed with a two-stage hypospadias repair. So I'll be quickly mentioning about what are the complications related with hypospadias repair. And the immediate ones, most common is bleeding and hematoma. However, postoperatively, it is acceptable to have some spotting on the diaper or the underwear, and the hematoma may be apparent for the first 3 weeks to first month. The edema could occur and stay on for 3 months. Wound infection is very unlikely, and even more, we don't give any prophylactic antibiotic for patients with distal hypospadias repair. We recently did a systematic review, which didn't show any significant benefit of giving post-operative oral antibiotic. However, the CKIDS protocol will give 1 dose of intraoperative pre-surgical incision IV antibiotic, cefoxitin or cefazolin. Wound dehiscence is very unlikely. However, it depends on your surgical technique, making sure that your knots are square knots and able to hold the tissue tight. Skin necrosis or flap necrosis depends on your surgical dissection of the dartos flap and making sure that you leave a vascular supply for the skin coverage. Likewise, for the flap necrosis, if you compromise your dissection of the vascularity, this can happen. Fistula may happen immediately after you remove the catheter, then basically it is a surgical error. And sometimes later on, fistula can only found when the patient were toilet trained. Inadvertent removal of the urethral stent or bladder spasm, it depends on the stent you use or a Foley catheter. However, if you're using a Foley catheter, I personally would advise not inflating the catheter, because after you deflate the catheter and removing it, you'll notice the balloon when deflated had accordion, and once you remove that, it will rip your whole repair. Hence, we usually do a stent or a catheter that the balloon port is not inflated and we tie it over with the glands. So for the surgical complications, urethral fistula is the most common one. It can range from 4 to 20%, depending on severity of the hepatitis and your approach. It is defined as two urinary stream because of an extra urethral opening, and the correction requires a second operation, which is usually performed 6 months after initial procedure. Fistula would happen mainly either it's a surgical error or you had a distal meatal stenosis. Hence, every time you had encounter a fistula, please evaluate the meatal opening and calibrate and make sure it is wide open. The reason of having a fistula with a meatal stenosis is due to increased pressure interluminally, and it will find it's a pop-off area, and the weak point would be the point where the fistula develops. Another complication is urethral stricture. It is more common among the TIP, and the reason why among the tuberous incised plate you'll have urethral stricture is because you're not incising the plate deep enough. How deep do you need to incise your plate is deep to the point that you're seeing the tunica albuginea. Urethral stricture is due to tightening of the reconstructed urethra within the glands. One way we do our reconstruction of the urethra or urethroplasty is we have a large bore catheter on while we're doing our suturing. And then the second part, after you finish your new urethral reconstruction, we remove the large bore and we put in a small bore towards end of the procedure. Symptoms of urethral stricture is when patients are straining or pushing upon urination, or you notice a thin or fine urinary stream. This also can result to fistula formation, as mentioned earlier. The correction requires a second operation at least 6 months following the prior surgery. Another complication is urethral diverticulum, which is due to outpouching of the reconstructed urethra, and this can be related to distal stricture or meatal opening, that is stenosis. Basically, it is characterized as ballooning of ventral aspect when a patient is urinating, or there is dribbling after due to retained urine on the diverticulum. This complication is commonly happen among patient procedure that you did the dorsal onlay, where you have a preputial flap onlay and there is lack of ventral support, or you didn't put additional dartos layer flap, then this may happen frequently. What are the risk factors for complication? According to literature, mostly Dr. Stantras will have some publication with Dr. Bush is a gland size of less than 40 millimeter. That's reason it's important to measure the gland size preoperatively, because sometimes we may give testosterone to increase the gland size. Proximal meatal location, particularly because you have a longer urethroplasty, and reoperation. Once you had a failure, the subsequent complication may be higher, and low surgeon volume independently increase the risk of complication. And recently we did a study at sick kids looking at the learning curve to achieve a competency. Based on our data, it's approximately 165 cases before you can achieve a total competency, including complication rate and over time. It is around 260 plus before you can be proficient with this procedure, or you can master the hypospatus repair. So again, the risk factor could be small gland size, particularly less than 40 millimeter. And one way is to increase the size to avoid complication. And the protocol we use at sick kids is 25 or 50 milligram, 3 doses, once a month. And we would give the last dose around 6 to 3 weeks prior to surgery to augment the gland size if the preoperative measurement is 40 millimeter or less. So for the surgical techniques, a single stage can only be done if the curvature is mild, as I mentioned, if it's less than 30 degrees, which you can do a dorsal plication. So where we do the dorsal plication using a non-absorbable suture, particularly we commonly use Prolin at the 12 o'clock position of the dorsum. This is the area where it is zone, nerve-free zone, because the neurovascular bundle are more lateral to the 12 o'clock position. You can either incise the tunica, or you can just place a vertical or horizontal mattress, as you can see on this image on the right lower corner. Then next, once you are able to correct the curvature, is the primary tuberalization. Basically, you tuberalize the urethroplasty or urethral plate by doing so with or without incision of the plate. If you aim to incise the plate, then you need to cut it deep enough to able to see the tunica albuginea. This is ideal for the glandular or mid-shaft hypospadias by doing a new urethra. So the term for the tuberalization could be tears to play, and there are other techniques such as Matthew or meatal advancement and glanduloplasty incorporated or magpie, particularly is ideal for glandular hypospadias. As I mentioned earlier, there's another approach you can do is an onlay island flap where you harvest the perputial or inner perputial skin, preserving the vascular strip and the inner foreskin onto the ventral urethral plate and sew it as an onlay fashion. This would increase the intraluminal size. However, again, you need to make sure you have an adequate ventral support with good dartos layer overlaying on the onlay island flap. If your curvature is so severe, then we opt to advise doing a two-stage hypospadias repair and make sure you're able to correct your curvature on your first stage. And we usually assess the curvature by doing artificial erection after doing your penile degloving. So what we'll do is after penile degloving, you'll do artificial erection. So the first image on the right upper corner is a very mild. You can do plication and you can correct it and proceed with your tuberization. However, if despite you did your degloving and there's tethering, particularly you need to do transection of urethra. So you can see on the image of the B, you need to start doing some ventral corporatomy even if you think the curvature were more than 30 degrees after urethral transection. And there is a few studies that show corporatomy with grafting. However, personally, I would not advise that. And there are some studies that show that if you do a graft over a graft, likely the graft won't take, even though there are a few studies that are able to show some success, but commonly the success rate may be low. So here are some example. The image on A and B is a single patient and C and D is another patient. So when you do a transection, as you can see on the image B, you can see the penis straighten. However, sometimes as the image on C and D after urethral transection, there's still the significant curvature. Then these are the cases that you need to do ventral corporatomies or deep 3 cuts on the maximum curvature down to the tunica albuginea. After which you can do either a grafting on the first stage if you didn't need to do a ventral corporatomies. However, if you did a corporatomies, there is what we call a STRAC procedure where you need to do a 3-stage hypospadias repair. The first stage is correction of the curvature. Second stage is grafting, either a perputial graft or buccal graft. And third stage is the urethroplasty. So this slide will show you different approach of the grafting, either from the prepuce on the right side of the slide, and on the left side is basically a buccal graft, either from the inner shape or lower lip. So what is important with the grafting is that making sure you're doing a pie crust or meshing your graft by making holes. The importance of making holes on the graft is to make sure that any fluids on the bed were able to drain out and not cause any hematoma affecting the take of the graft. Second important thing that you need to do is quilting, which means you will be putting a small suture to attach your graft onto the recipient bed. We usually use 7/0 PDS or 6/0 PDS or Vicryl to make sure they are able to attach to the recipient side. And then usually after placing the quilting stitch, we make sure to place bolster. And the way I do bolster is Vaselinized gauze on top of it. And you literally suture the bolster on top of the graft by using the lateral skin edges to wrap around it. And the most important thing is not moving the dressing for at least 5 days. The reason why is the graft have 3 processes. The first process is what we call imbibition, and it takes place within 24 to 48 hours, where the graft will take its nutrient from the recipient bed. And the next phase is what we call the inosculation, where the graft will start forming vascularization with its recipient bed, and it occurs up to the 5th to 7th day of post-surgery. Hence, typically, I would do removal of the catheter at the same time the dressing after 7 days, and making sure that there is new vascularization on the graft already. And by the time you will be able to have an idea whether there's hematoma or the graft had taken well. The next phase is what we call remodeling, and it can occur up to 3 months or more. Hence, we have our patient come back to our clinic after 3 months to evaluate how much degree of contracture happened. For perputial graft, the contracture may occur up to 40%, while for the bottle graft, the contracture or shrinkage can happen up to 20%. So again, for a surgical technique for 2-stage hypospadias repair, we commonly advise doing it after 6 months, and some may advocate after 12 months even. And basically, you're doing retuberalization of the graft. A key point for tuberalization is that whenever you construct the urethra, you need to have a covering over the suture line. It is important to develop either a dartos flap or a tunica vaginalis flap. And we have a study at SickKids that showed if you have double layer of a flap, dartos layer, the incidence of fistula have significantly lower than doing nothing. So if you can do 2 layers, if not, at least 1 layer to flap over the suture line. As I mentioned earlier, either you can do a dartos flap or tunica vaginalis flap, particularly for the severe hypospadias. If there is also undescended testicle, we won't do the undescended testicle procedure at the first stage, because on the second stage, likely you will need the tunica vaginalis flap, and you can harvest that at the same time when you're doing your tuberalization. Now, I'll quickly run down the outcomes for proximal hypospadias repair and different approaches. So the complication, as I mentioned earlier, urethral stricture is most common among the TIP for proximal hypospadias repair. The lowest is onlay because it had a significantly better intraluminal caliber. However, the diverticular, as I mentioned earlier, you only have the highest incidence. Otherwise, for the meatal stenosis, fistula, dehiscence, recurrent curvature, irido repairs, basically there is no significant difference between approaches. Using uroflowmetry post-proximal hypospadias repair, the TIP would have a lower maximum flow, while the onlay would have the highest maximum flow. Again, it's the same principle, because the TIP, likely you'll have some fibrosis, especially if you're not cutting enough deep to the tunica albuginea. So here's a report of a proximal hypospadias repair outcome from the several big institutions, such as the Hospital for Sick Children at Toronto, the Boston Children's, the Texas Children's, where Dr. Snodgrass initially worked, and CHOP from Philadelphia. The proximal hypospadias repair complication may reach as high as 50%, and this is pretty consistent across all these big institutions. And we'll be going to our summary. Hypospadias is one of the most common congenital genital anomaly, and description and additional evaluation are needed if there's concomitant anomaly, particularly undescended testicle. Indication for surgical repair mainly functional, although individualized approach for cosmetic indication. Surgical approach depend on severity and degree of curvature. First and primary hypospadias repair is most critical and important to determine your surgical outcome, and coverage layer is important to avoid subsequent complication. For proximal hypospadias repair, to date, the complication rate remains high, and it is important to discuss this with the parents, that you'll probably do a multi-stage repair rather than just giving a hope that you'll be only doing a 2-stage repair. Again, I'll be quickly summarizing the recommendation from EIU guideline. So primary hypospadias repair should be within 3 of age, ideally within 24 months. The therapeutic objective of correcting the penile curvature, forming new urethra with adequate size, and bringing the new meatus to the typical glans penis. If possible, make a overall acceptable cosmetic appearance, particularly for the distal hypospadias. Androgen stimulation using testosterone to increase penile length is acceptable and is an option. The complication rate for distal hypospadias is approximately 10 to 15%, while for the proximal can range from 25% to 68%. Sexual function post-hypospadias repair are preserved, and deformity could cause a psychological issues. Again, quickly running down for evaluation, if a patient have isolated hypospadias and it's severe with cryptorchidism, karyotyping is indicated with additional endocrine workup. Counseling a caregiver about the functional indication for the surgery, while the cosmetic or psychological indication may need to weigh between the risk and benefit. Patient with proximal hypospadias with small appearing penis, reduced gland size, you can do androgen stimulation. And for distal hypospadias, you can do tubulization, either tears to play, TIP, onlay, or two-stage hypospadias repair for severe type and significant curvature. Ensure follow-up at least 2 years or until a patient were toilet trained, because most of the stricture or fistula are not noticed until they are toilet trained. Use a validated objective scoring system to assist in evaluating your own functional and cosmetic outcome. And there is a published objective scoring as hypospadias outcome penile evaluation system, which is the HOPES or the host. So here are my references and suggested readings. If there's any questions, you can have my email, and you can directly email me. I can give you further educational material. Again, thank you for inviting me to the PUA Mindanao chapter and sharing my experience from my several training at the Hospital for Sick Children. Thank you, and have a nice day.
next speaker is a fellow of Philippine Urological Association and a consultant of the Section of Urology, Department of Surgery, University of Santo Tomas Hospital in España, Metro Manila, Philippines. Dr. Martinez obtained his medical degree from the Faculty of Medicine and Surgery of the University of Santo Tomas Hospital, Philippines in 2007. He finished his urology residency training in that same institution in 2014. He had his post-residency training in male infertility in Cleveland Clinic in Ohio and in University of Miami in Florida. He completed the basic and advanced microsurgery training from New York Presbyterian Hospital, Weill Cornell University. His interest includes male infertility and microsurgery. Let us all welcome Dr. Marlon P. Martinez.
Good day to everyone. First of all, I want to thank the Philippine Urological Association Mindanao chapter with their course director, Dr. Nimrod Firaza, for the invitation to be part of their first online postgraduate course. So we are tasked to provide learning hacks to simplify and cater the needs of patients in a low-resource setting from the subspecialty of male infertility. The standard practice of male infertility requires affiliation to a fertility clinic and IVF center. If you don't have the setup, it is important to know when to refer to this specialized center. So some of the treatment options for male infertility might require assisted reproduction, which might not be in congruence with your religious belief. But for the sake of discussion, we will be talking about this treatment option. Remember that management of infertile men starts in the clinic and not in the operating room, meaning surgery is not always a treatment for these men with poor reproductive potential. For your practice, I recommend you to use these guidelines from the American Urological Association, American Society for Reproductive Medicine, and European Association of Urology. They have good summaries on how to treat and manage men with infertility problems. This can also serve as a guide to your male infertility practice. Basically, infertility is defined as the failure to achieve clinical pregnancy after 1 year of regular, unprotected sexual intercourse. Minimum initial evaluation includes a good reproductive history and at least one semen analysis. If these reveal abnormal results, a second semen sample is required for evaluation and some additional tests, like the hormones, genetic testing, and imaging of the male reproductive tract. So I personally made this evaluation form for my patients in order to help me not miss any single detail, which might be very relevant to the cause of their infertility. Okay, you can make your own evaluation form that can assist you in your investigation of the etiologies of your patients. So this form includes the infertility history, childhood and development, gonadotoxin exposure, medication history, and also the personal history, sexual history, family history, and previous surgeries. So relevant details should not be neglected because this might be the only key for a successful pregnancy. This is also my personal patient's record. Again, you can make your own chart for your patients. So this includes the semen analysis results. For me, the most important parameters are the volume, the pH, the sperm concentration, motility, and morphology. Then the physical examination, assessment, and plan. So physical examination should focus on the genitalia, the measurement and consistency of both testes, presence and consistency of the vas deferens and the epididymis, the presence of varicocele, presence or absence of secondary sexual characteristics, and digital rectal examination. So I recommend you to use an orchidometer or a caliper to get an estimation of the size of the testis. I personally use an orchidometer in my practice. So less than 15 ml is considered small testis. So color red beads are considered normal sizes. So hormonal testing is indicated in men with sperm concentration less than 10 million per ml and to those with sexual dysfunction. It is very important to do a detailed history, extensive physical examination, and hormone profile, because by this you can differentiate between obstructive with non-obstructive azoospermia in about 89 to 96% of the time. So genetic testing is indicated in men with sperm concentration less than 5 million per ml, and in men with non-obstructive azoospermia secondary to testicular failure. Ideally, karyotyping and Y chromosome microdeletion should be requested, but in most of the local setting, karyotyping is only available. And always consider the age of the female partner in offering treatment options for these infertile couples. You may offer surgery in men with younger female partner and assisted reproduction in men with an older female partner. So etiologies of male infertility range from congenital to acquired causes. Despite of any effort to determine the possible underlying causes of male infertility, about 30% of them will remain undiagnosed, hence the term idiopathic. And there are some with normal semen parameters that will remain infertile in about 30% of cases, hence the term unexplained infertility. And these infertile men with idiopathic causes are usually left to choose between assisted reproduction or empiric medical therapy. The European Academy of Andrology published a guideline on management of infertile men with idiopathic causes. So empiric medical treatment for idiopathic male infertility is considered as off-label treatment. You can give antioxidants, follicle-stimulating hormone, anti-estrogens, and remember, testosterone is contraindicated in men desiring to be a father and should not be given to them. Antioxidants are one of the most commonly given medications in male infertility. So based on the recent Cochrane database of systematic reviews on the use of antioxidants for male infertility, use of antioxidants is associated with significantly increased clinical pregnancy rate and live birth rate, and significantly decreased miscarriage rate. Antioxidant use is likewise associated with a significantly lower sperm DNA fragmentation test. If you use the terms antioxidants and male infertility, it will generate more than 1 million results. Because of the availability of these over-the-counter medications, it is prone to discriminate use, leading to antioxidants paradox. Remember that the reactive oxygen species are necessary for normal physiologic sperm functions like the acrosome reaction and capacitation. And excessive use of antioxidants can cause reductive stress, resulting to infertility. This is the most recent systematic review on the different antioxidants on male infertility. The 5 most commonly used ingredients are vitamin E and C, zinc, folic acid, and selenium. Whereas the 5 ingredients with most evidences are vitamin E and C, zinc, L-carnitine, and coenzyme Q10. In all, only 22% of ingredients used were found to have published evidence for improvement in semen parameters, and only 17% of ingredients had data published showing a positive result. In contrary to initial beneficial outcomes with antioxidants use, this recent trial showed contrasting results. Males randomly assigned to receive a daily intake of these antioxidants for the duration of 3 to 6 months showed no significant difference in the improvement of sperm concentration, motility, morphology, and sperm DNA fragmentation. Likewise, no significant difference was seen in the live birth rate between the 2 groups. The question now is to give or not to give these antioxidants as the treatment option for men with idiopathic causes of infertility. So we did several studies on the use of antioxidants in the management and treatment of these men with poor reproductive potentials. Yes, antioxidant supplementation is considered as one of the treatment options for managing these infertile cases. And our conclusions are the following. There is a growing evidence on the beneficial effect of antioxidant use, but most of the studies included are of poor methodological quality technique. A well-designed, large randomized placebo-controlled trial should be done in order to arrive to a definite conclusion. So overall, despite of its drawbacks and limitations, antioxidant use is still a valid option for treatment of infertile men. My recommendations, if the patient is already taking antioxidants on consultation, let the patient continue the intake. Make sure you prescribe antioxidants with the most evidence. Next drug is the clomiphene citrate. So clomiphene citrate is the most commonly prescribed drug for male infertility. So in this meta-analysis by our very own Dr. Mike Chua, clomiphene citrate is associated with a significantly increased improvement of the sperm concentration and motility, significant increase in FSH and testosterone, and more importantly, it is associated with a significant increase in pregnancy rate. Important points, you do not give clomiphene citrate in all infertile men. You only give this drug in men with low testosterone and normal or subnormal LH, regardless of FSH level. You can give 25 milligrams, one tablet every other day for 3 months, and repeat the semen parameters analysis. So when do you give aromatase inhibitors? In those men with low testosterone and testosterone estrogen ratio less than 10. So you can give anastrozole 1 milligram per tablet, one tablet every other day for 3 months, then repeat semen analysis after 3 months. Again, testosterone is contraindicated in men desiring to have biological children. Yes, initially it will increase the level of your testosterone, but exogenous testosterone will send negative feedback to the pituitary gland and the hypothalamus, thereby shutting down the secretion of your gonadotropins, the FSH and the LH, leading to low testosterone production and abnormal spermatogenesis. In our review on the medical treatment of male infertility, medical treatment for idiopathic causes of male infertility is off-labeled and only indicated for men with hypogonadotropic hypogonadism. Moving on, varicocele is considered as the most common cause of male infertility we encountered in our local setting. This can be seen in 15% in normal male population and 40% in men presenting with infertility. So typical indications for surgical repair of varicoceles are infertility, reduction in the size of the affected testis, and intractable pain. But how about the unusual indications for doing varicocelectomy, specifically in men with varicocele and non-obstructive azoospermia and men with elevated sperm DNA fragmentation? It was estimated that varicocele could be identified in 5 to 10% of patients with non-obstructive azoospermia. In this systematic review and meta-analysis on varicocelectomy in men with non-obstructive azoospermia, doing varicocelectomy will result in the return of sperm in the ejaculate in more than 40% of patients. Compared to azoospermic men without varicocele repair, sperm retrieval rate is significantly higher in men who underwent varicocelectomy. Likewise, it is associated with higher clinical pregnancy rate and higher live birth rate. But make sure you do varicocelectomy only in men with non-obstructive azoospermia, meaning in those men with high FSH, small testes, and flat epididymis, and not in men with obstructive azoospermia. If no pregnancy nor the presence of sperm in the ejaculate after surgical correction of the varicoceles, refer this patient for sperm retrieval in the form of microdissection testicular sperm extraction with IVF. How about the role of varicocelectomy in men with high sperm DNA fragmentation? In a multi-center study by Sandro Esteves, men with leukocytospermia and men with varicocele had the highest sperm DNA fragmentation level. In 2016, a panel comprised of 5 urologists and 1 andrologist with expertise in male infertility were selected to provide evidence-based recommendation for sperm DNA fragmentation testing. These are the most commonly used tests for sperm DNA fragmentation: the sperm chromatin structure assay, COMET assay, sperm chromatin dispersion test, and the tunnel assay. In our center, we're using the sperm chromatin dispersion test. Sperm with halo is considered normal, while sperm without halo is considered containing fragmented DNA. So DNA fragmentation index of more than 25% is considered as an abnormal result. Based on the teachings of our mentors since residency, men with varicoceles with normal semen parameters are not recommended to undergo varicocelectomy. So one of the indications for sperm DNA fragmentation testing is for men with clinical varicoceles. The recommendation: men with low-grade varicoceles with borderline or abnormal semen parameters, and men with high-grade varicocele with normal semen parameters. If their sperm DNA fragmentation testing reveals elevated levels, the recommendation is to do varicocelectomy for this set of patients. So now we can offer varicocele repair even in men with normal semen parameters and elevated DNA fragmentation index, although this is still controversial globally. In a meta-analysis done by Wang et al. On the relationship between varicocele and varicocelectomy and sperm DNA damage, the overall estimates show that patients with varicoceles had significantly higher sperm DNA damage than controls, with a mean difference of 9.84%. And varicocelectomy can improve sperm DNA integrity with a mean difference of 3.37%. In addition, sperm DNA fragmentation is 5-fold lower in testicular sperm than ejaculated sperm. So with that finding, use of testicular sperm for IVF is significantly associated with higher live birth rate and significantly lower miscarriage rate. In this systematic review, testicular sperm is preferred for IVF in men with high sperm DNA fragmentation and severe oligozoospermia. So use of testicular sperm instead of ejaculated sperm in recurrent IVF failure might be an option. Despite these findings, this is still controversial due to lack of low quality evidence available. So the best technique for varicocele is the microsurgical approach. Microsurgical varicocelectomy is significantly associated with increased improvement of the sperm concentration and motility, significantly decreased complication rate and recurrence rate, and more importantly, significantly increased pregnancy rate. I did a survey among urology residents last 2019. About 68% of them are only using surgical loop. So in this study by Sang et al., they compared the intraoperative findings between loop-assisted and microsurgical varicocelectomy. Compared to loop-assisted varicocelectomy, microsurgical varicocelectomy is associated with a significantly higher internal spermatic arteries and lymphatics identified and preserved, and significantly higher internal spermatic veins ligated. Loop-assisted varicocelectomy is associated with higher internal spermatic veins missed. So use of vascular Doppler also improves intraoperative outcomes. I personally use 8 MHz vascular Doppler for varicocelectomy procedures. So use of vascular Dopplers improve the identification and preservation of the blood supply of the testis. Significantly higher veins ligated and significantly higher arteries preserved are associated with vascular Doppler use. So going back to the survey, only 6% had either assisted or performed microsurgical varicocelectomy with intraoperative Doppler. So surgical microscope is not readily available in other hospitals, especially in the province, that can be used for varicocelectomy. Expensive cost is mainly the reason. It is only available in higher and advanced centers. So I look online for cheaper surgical microscope, and I found this portable microscope from Lazada, which only costs 1,000 pesos. So using an application called Camera Fi, which can be downloaded to your phone, it can be connected to your cell phone, laptop, or any monitor. So before the pandemic, we started doing this comparative study on the intraoperative findings between this surgical microscope and portable microscope from Lazada. So we used two monitors side by side to compare the intraoperative capture of both microscopes. So the right monitor is connected to the surgical microscope Leica, and the left monitor is used to transmit the capture from the portable microscope that is wirelessly connected to my cell phone through the app Camera 5, and this is being projected to the left monitor for my cell phone by screen mirroring. These are the images captured by the portable microscope during subinguinal incision, during spermatocord isolation, isolation of the vas deferens, identification of veins, and ligations of the veins. Our preliminary results show the following drawbacks: the stability of the assistant hand while holding the camera, the need for a monitor, sterilization of the camera, difficulty adjusting the brightness, and the main finding, it cannot replace the surgical microscope. You can try it. If it is useful to you, you continue using it. So for me, azoospermia does not equate to infertility. There is still a chance of having a biological children. So non-obstructive azoospermia is more common than obstructive causes. So absence of sperm in the ejaculate does not necessarily mean no sperm within the testes. In fact, if you look inside the testes of men with non-obstructive azoospermia, about 25 to 70% you can find sperm depending on the etiologies. On the other hand, men with obstructive azoospermia, about 100%, you can find sperm on sperm retrieval. I personally made this diagram to easily differentiate obstructive from non-obstructive azoospermia. So men with small testes and high FSH, most likely they have non-obstructive azoospermia. On the other hand, men with normal FSH and enlarged testes, most likely they have obstructive azoospermia. Mycotese with IVF is the gold standard for the treatment of men with non-obstructive azoospermia. You can do reconstruction or sperm retrieval with IVF for men with obstructive azoospermia. So when do you do testicular biopsy for men with azoospermia? So you perform biopsy in men with azoospermia, in men with normal sized testes, at least one palpable vas deferens, and a normal serum FSH level. For the reason that men with a histologic finding of non-obstructive azoospermia, specifically maturation arrest, can also present with normal sized testes and normal FSH level. And we do not offer microsurgical reconstruction for men with non-obstructive azoospermia. For men with obvious diagnosis of non-obstructive azoospermia, like in those men with small testes, low testosterone, and high FSH, testis biopsy is not recommended. The ideal setup is a double setup. This is what we do in our center. So tissue extracted will be submitted both for biopsy and to the embryologist. The embryologist will look for sperm, and if there is sperm, we freeze it. If IVF center is not available in your setting, you can still do testicular biopsy in men with azoospermia normal size testis, and normal FSH level. If biopsy shows normal spermatogenesis, you can do reconstruction or refer to a specialist who can do these microsurgical techniques or for sperm retrieval plus IVF. But if the biopsy shows maceration or rest, refer the patient for sperm retrieval by microtessay with IVF. Again, no sperm in the ejaculate does not equate to no pregnancy, and it does not equate to no chance of being a father. So next, the World Health Organization declared the COVID-19 outbreak a global pandemic last March of 2020. So SARS coronavirus 2, which is the causative agent of COVID-19, gained its entry into target cells by the interaction between its virus spike protein and cellular angiotensin converting enzyme 2 and the transmembrane serine protease 2 of the host cells. It was found out that the angiotensin converting enzyme 2 is highly expressed in different tissues, and testis is among the top 5 of those expressions. So the impact of COVID-19 on male infertility is still under study due to the infancy of the reports. The interesting questions are the following. Is the virus present in the semen? Can be this virus transmitted sexually? And what's the effect of this virus on the reproductive potential of men? So initial studies showed absence of sperm in the semen or absence of the virus in the semen. So last May of 2020, the first study reported the first finding of the virus in the semen of men with coronavirus disease. So 6 out of 38 men with COVID-19 had the virus in their semen. 4 of them were during active infection, and 2 of them were on recovery phase. In other study, there is no evidence of sexual transmission of coronavirus. COVID-19 is associated with decreased sperm concentration and motility in men with moderate infection. And men with COVID-19 is associated with lower testosterone level and higher LH and prolactin level. But due to small sample size and short follow-up, no strong conclusion can be made, and still many unanswered questions. Personally, I believe that these can be detected in the semen, the virus can be transmitted sexually, and the virus has a negative effect on male reproductive potential. A proposal by the group of Sandro Esteves was made to prioritize men needing urgent male infertility services during this pandemic. So those men older than 50-year-old who are candidates for assisted reproduction, those men at reproductive age affected by inflammatory diseases, and men with severe male factor infertility under medical or surgical treatment, aiming at improving sperm quality or quantity, and lastly, cancer patients before the initiation of surgical treatment, chemotherapy, or radiotherapy. In these sets of patients, diagnostic semen analysis and sperm cryopreservation should not be delayed and should be prioritized. So for my take-home messages, first is perform good reproductive history and physical examination. You may use male infertility guidelines from the AUA, ASRM, and EAU. You may give antioxidants, give clomiphene citrate in men with low testosterone or subnormal or normal LH, and do not give exogenous testosterone. You may offer varicocelectomy in men with non-obstructive azoospermia and in men with high sperm DNA fragmentation level. Azoospermia does not necessarily mean no chance of being a father. So COVID-19 leaves many unanswered questions. Postponing male infertility services like a semen analysis or sperm cryopreservation in these infertile men could compromise the prospect of biological parenthood. So offer treatment option with the most evidence and with the most superior outcomes. And lastly, and more importantly, doctors are only human. So despite all our exhaustive efforts, we cannot diagnose and treat all these male infertility cases. And that is the reality. With that, thank you for listening and keep safe to everyone.
Our next speaker is a fellow of Philippine Urological Association, a fellow of Philippine Society of Uro-Oncology, and a current consultant of UST Hospital, Department of Surgery, Section of Urology, and an instructor of UST Faculty of Medicine and Surgery, Department of Surgery in Manila. Dr. Alpajaro obtained his degree as Doctor of Medicine at the University of Santo Tomas Faculty of Medicine and Surgery, where he graduated cum laude in 2008. He then had his residency in that same institution and finished in 2015 and was awarded Excellence in Academics and Research by the UST Department of Surgery. He became a visiting assistant professor at the University of California, Davis Department of Urologic Surgery from 2017 to 2018 and finished his fellowship in urologic surgical oncology in 2008. Over the years, he has published in various peer-reviewed journals and textbooks, both locally and abroad. He is currently an instructor at the UST Faculty of Medicine Surgery. His interests include urologic oncology and cancer surgery. Let us all welcome Dr. Siegfried Ian R. Alpajaro.
Good day, everyone. I would like to start by thanking PUA Mindanao. It is my great pleasure to be here today. Special thanks to Dr. Rod Hipol, the PUA Mindanao President, esteemed officers of the chapter, and Dr. Nimrod Firaza for this invitation to talk on hacks in urologic oncology. Here are my disclosures. So treatment decisions and management starts with proper diagnosis of the disease. So I begin with hacks in imaging and diagnosis. The classic lesion of prostate cancer on ultrasound is the hypoechoic nodule in the peripheral zone. Although this is only true in roughly half of the cancers. But the rule is, unfortunately, ultrasound-guided transrectal biopsy has a very high false positivity rate. And this likely stems from the fact that 40% of cancers do not appear as a classic hypoechoic lesion that is described in our textbook. The role of MRI, particularly multiparametric MRI, has gained ground over the past 5 years or so. Several large multi-center randomized trials have been published in the most prestigious scientific journals and have reported the superiority of MRI-guided prostate biopsy. These studies have shown that in biopsy-naive men with elevated PSA and with the use of PIRADS scoring system, the accuracy of diagnosis of significant prostate cancer can be increased while avoiding biopsy and its morbidities in men who do not need a biopsy. The NCCN now recommends use of multiparametric MRI as part of decision-making tools prior to prostate biopsy. Likewise, the NCCN recommends the use of MP-MRI in men with prior negative biopsy but where the suspicion of malignancy has not been ruled out. As a review, multiparametric MRI uses 3 parameters. The first one is DWI, or diffusion-weighted images. This determines the degree of cellularity and neoplastic component, and it's actually the dominant sequence for assessing peripheral zone of the prostate. The T2-weighted images, or T2W, provide high-resolution zonal anatomy and periprostatic anatomy, and is the dominant sequence in the transitional zone. It's also useful for loco-regional staging. And then finally, you have DCE, or dynamic contrast enhanced imaging, and this determines the presence of neovascularization that's associated with cancer. So for those with ambiguous findings, particularly in the peripheral zone, it's the final arbiter. So in summary, multiparametric MRI has been shown to improve diagnosis of clinically significant prostate cancer. It's used as a guide to avoid unnecessary biopsies with its accompanying morbidities, and helps avoid the overdiagnosis of clinically insignificant prostate cancer. However, the problem is it can be expensive to have as a modality. It's time-consuming. Some patients would complain that it takes 45 minutes, 1 hour, or even more just to perform this procedure. So those, especially with claustrophobia, would have trouble doing this. And finally, the contrast administration precludes utility in those with allergy or poor kidney function. Hence, there is an increasing attention to biparametric MRI, which uses only DWI and T2 weighted images or sequences, and then omits DCE, which is the part of the MRI sequences that would require contrast. And so we come to our first uro-oncology hack, which is biparametric MRI instead of multiparametric MRI. And actually, there's increasing number of studies already to show that this is actually a viable option. There are studies from the US and Asia showing biparametric MRI is a good alternative to the multiparametric MRI. And actually, studies would show or conclude that diagnostic performance of biparametric MRI is comparable to multiparametric MRI. There are also studies or data from Europe showing the same. Finally, there's a meta-analysis spanning 242 studies involving a total of 2,142 patients. And the conclusion was unanimous in stating that biparametric MRI and multiparametric MRI are comparable. Although pending large multicenter RCTs, current data would suggest that biparametric MRI is a reliable alternative to multiparametric MRI. In summary, the advantages of biparametric MRI are that it's cheaper, there's less examination time, there's no need for contrast, so those with contrast allergy or patients with borderline or poor kidney function can also benefit. The only disadvantage is that the ongoing large randomized trials on non-inferiority of biparametric to multiparametric MRI are still ongoing. Then now we proceed with hacks in surgical management of urologic cancers. The second hack I found useful, although some of you might already be employing, is that of using self-retaining retractors. Aside from providing excellent exposure of the surgical field, you are able to channel your manpower to actual assisting and not just retracting for you. The luxury of having multiple surgical assists is not always present, and special retractors can eliminate this need. So this is a Bookwalter retraction system. It's commonly used for kidney transplant, but definitely is effective in almost any type of urologic cancer surgery. Meanwhile, here's the OmniTrack system. Some surgeons actually prefer this, citing the maneuverability of the poles and arms in this system, and that you're able to adjust down to the last inch. Okay, other ring retractors, such as this, is equally useful. This one is actually a made-to-order retractor at a local machine shop. Okay, so you can have this done in a local metal shop, machine shop. So this is just a quick video on how to set up and mount this self-retaining system. You can appreciate the very good exposure it provides even for deep pelvic surgeries. So our second uro-onc hack is the use of self-retaining retractors in your surgeries. The advantages, it can provide superior surgical exposure, can be used in all open cancer surgeries, be it the kidney, bladder, ureter, prostate. It's generally easy to set up and mount and can obviate the need for more assistance involved where there may be limited manpower. The disadvantages, of course, is that some retractors may be expensive and it may require initial capital or investment. The third hack which I use is doing a continuous running suture for vesicourethral anastomosis in open radical prostatectomies. Okay. The textbook description in Campbell and Hinman is that of an interrupted VUA, which uses 6 to 8 throws to anastomose the urethra and the bladder neck. This, of course, remains a feasible technique, but I will show you some potential advantages of the continuous technique. There are at least 2 local studies I will show. First is that of Martinez et al. Involving a retrospective review of outcomes in interrupted versus continuous VUA. In their technique, that they use 2 3-0 absorbable monofilament sutures tied together to create a double-armed ligature. First bite at the 5 o'clock on the posterior bladder lip and another at the 7 o'clock on the other side of the ligature. The corresponding urethral side is gathered with an inside-out suture. Sutures are not immediately pulled. Instead, an O-silk is used to secure a loop so that there's still a distance between the bladder and the urethra where there's ample space for you to work and continue your anastomosis. Repetitious passes are made for the left at the 330, 230, 130 position and on the corresponding opposite side. Use alternating mosquito and Kelly forceps to mark the throws to avoid confusion. And then once both sides are done, each throw will be successively tightened, going into the 12 o'clock position, and then prior to tying the 12 o'clock, a leak test may be done. So another local paper, which I co-authored during my residency, also compared running versus interrupted VUA. Of course, this technique will require a relatively long learning curve, but it's definitely reproducible once you get used to it. So this video just further illustrates the VUA by a continuous running suture. Internationally, a meta-analysis of 9 studies involving 1,475 prostatectomies were done. The study concluded a potential advantage in catheterization time, anastomotic time, and rate of extravasation during cystogram post-op in the continuous technique. Although it did note that most reports are retrospective or small in terms of the number of patient population, so ultimately it's still the surgeon's experience and preference that's important. However, it's worth considering as a hack using continuous VUA. Potentially, there are superior outcomes in terms of leak rate, time of catheterization post-operatively. It's also cheaper because you only need 2 sutures, whereas you need 6 to 8 sutures when you do interrupted. Of course, a disadvantage would be the initial learning curve for running anastomosis, since textbook description, or most of us were actually trained during residency with an interrupted technique in the VUA during radical prostatectomy. On to the next hack and somewhat controversial topic for uro-oncologists is that of pelvic lymph node dissection for prostate cancer. So the role of lymph node dissection, or LND, in prostate cancer is somewhat blurry, and limiting, or if possible, avoiding it is a useful hack. So this slide shows the different anatomic limits of lymph node dissection. We do know that vital structures like nerves and vessels are in the way of dissection too, meaning the more manipulation or the more dissection, the more likely you are to injure surrounding structures. Also, this will result to a longer operative and anesthesia time, and for a procedure with unclear oncologic benefits, that might not be a good deal. In a large, well-organized meta-analysis of 66 articles encompassing over 275,000 patients, performance of lymph node dissection in prostate cancers did not translate to improve biochemical and clinical recurrence, and offering no survival benefit. Furthermore, lymph node dissection had adverse effect on OR time, blood loss, hospital stay, and post-op complications, like, for example, lymphoseals. The conclusion of this large meta-analysis was that lymph node dissection and its extension had no clear benefit and only appeared to result to worse intra and perioperative outcomes. So bottom line, not all radical prostatectomies will require lymph node dissection. Therefore, proper patient selection is essential and key. Which brings us to the utility of nomograms that predict disease stage and lymph node involvement. And the most famous would be that of Dr. Alan Partin. All of us urologists would have heard of the Partin table of nomogram. So looking at it, looks toxic and cumbersome actually to use, but a hack I maximize and it's readily available are validated online nomograms. So for instance, here, online nomograms such as these on the screen are accessible and are actually free of charge. Your job would just be to key in items such as PSA, clinical stage, Gleason grade, etc. And the percent probability of lymph node involvement will be calculated real time. And there's even provision for MRI-based biopsies, such as this Briganti nomogram from Italy on the right side of your screen. Here's the Sloan Kettering nomogram. Now, you might see different nomograms. Most of them have already been compared by studies showing no significant difference. So it's up to actually your preference now. And then you set the threshold, probably if you 5 to 7% lymph node involvement would be sort of the deciding cutoff for lymph node dissection. So most would, if they see something like above 5% or above 7% likelihood of node involvement, then you will perform lymph node dissection in your radical prostatectomy. Okay? So the fourth hack I want to share is use lymph node dissection sparingly, maximize the use of nomograms. The advantages would be less perioperative morbidity like vessel nerve injury, lymphatic leak, leading to lymphocyl, less operative and anesthesia time if LND can be avoided. Available online nomograms are also very easy to use. Of course, the disadvantage is if improperly staged and lymph node dissection is omitted, then you may inadequately stage pathologically this patient. So important to properly stratify pre-operatively. And now we proceed to the next step of uro-onc hacks, those pertaining to management of metastatic prostate cancer. So this is a slide we often see showing the landscape of prostate cancer as a whole. Take note that as urologists, we are the primary caregivers until late in the castrate-resistant state, when the first and second line modalities have already failed. The field of prostate oncology is among the most dynamic areas of studies. We have two former Nobel Prize winners to thank. First is Dr. Huggins, who together with Dr. Hodges discovered that prostate cancer can be arrested with castration after they experimented with dogs in the laboratory. Next is Dr. Shally, whose works paved the way to understanding of hormonal agents as we know today, and now forms the backbone of androgen deprivation therapy. The fifth hack is well known to everyone but has largely been supplanted by medical treatment. It is, however, still very viable, especially in developing countries like ours, where cost is a consideration. So, is there a role still for surgical castration or orchiectomy? The answer is yes. And we actually have to remember that it's backed by science. So, in an important meta-analysis in the 2000s, Seidenfeld and his team studied a total of 1,900 patients. They compared surgical castration or orchiectomy with LHRH agonist injections, the ones that we use up to this day. With overall survival as the primary endpoint, they concluded that the two methods of castration had no difference. So they are equivalent in terms of overall survival and in other outcomes, including progression-free survival and time to treatment failure. Now, this table neatly summarizes medical versus surgical castration. The advantage of surgical is that there is immediate attainment of castrate-level testosterone. No flare is expected, so no need to co-administer with an anti-androgen. So, of course, orchiectomy is way more economical, especially in patients who are trying to save money is an issue. Drawback, of course, is that there's irreversible, and it's irreversible, and there might be some psychological impact to the patient. So be aware of that. So even in the 2020s, surgical castration as an option should remain in our discussion with our prostate cancer patients, especially when cost is an issue or if compliance and access to hormonal injections are anticipated. So finally, we proceed with the last hack, which I'll discuss with you. So you might see the red asterisk. The reason is this might be a little controversial, and so far, admittedly, no level 1 evidence of data available for this hack, but there are beginning reports showing that it might be possible. So the hack is dose adjustment of hormonal agents like enzalutamide, abiraterone, when given with ADT for metastatic prostate cancer. Now, basing on your goals, you might consider this and discuss this with your patient. Quick review, we see that prostate cancer treatment landscape is rapidly changing. In particular, agents used late in the disease or previously used late in the disease, meaning in the castrate-resistant disease space, is now being introduced as upfront therapies for metastatic prostate cancer at the earliest hormone-sensitive disease space. The different guidelines would now list as level 1 recommendation, giving ADT with an additional agent, either abiraterone, enzalutamide, apalutamide, for those with high volume metastatic disease, probably docetaxel. But the sort of the trend now is giving ADT with a combination or with another drug, okay? So this is just a summary of the big landmark trials. The CHARTED and STAMPEDE trials support the use of upfront docetaxel with ADT in MHSPC, that's hormone-sensitive disease. The LATITUDE and STAMPEDE showed superior outcomes with upfront abiraterone with prednisone with ADT. Meanwhile, the ARCHES and ENZAMET showed significant benefit in adding enzalutamide to your upfront treatment. And most recently, apalutamide as an upfront treatment with ADT has been approved based on the TITAN trial. Now, all of these agents significantly improve outcomes compared to the standard of care, which is ADT alone, prolonging overall survival among other parameters. That is why now, this is how the NCCN guidelines would look like in 2020. As you can see, the level 1 or category 1 recommendation would be ADT with an additional agent. Likewise, of course, we all know even before that for castrate-resistant disease, the combination therapies would be superior to just ADT alone. The TAX and SWOG studies has established docetaxel many years ago as a treatment. The PREVAIL trial for enzalutamide and the Cougar 302 for abiraterone has established their roles in the castrate-resistant setting. Now, there's no doubt that in metastatic hormone-sensitive and in pre- and post-chemo metastatic castrate-resistant prostate cancer setting, novel AR antagonists and abiraterone provide significant survival benefits, so no question. However, the problem is the high cost of these novel agents. So, for example, abiraterone, which is given 4 tablets, meaning 1,000 milligrams per day, would cost approximately up to 100,000 pesos a month. And then enzalutamide, which is 160 milligrams per day, would cost approximately 110 to 120,000 a month. And probably only 1% of our population can afford this, or maybe even less. Okay, so the question, to offset the high cost without sacrificing treatment efficacy, is a lower dose regimen available or possible? And can these agents be taken intermittently based on PSA or clinical response? So there's a small report on older men, those more than 75 years old with diagnosed castrate-resistant prostate cancer. In this study, although it was a small cohort, they compared standard versus low dose enzalutamide. So their dose of enzalutamide was half dose or lower, so 80 milligrams or lower in the study group. The primary outcome was PSA response. What they reported was that in the 59 patients who were included in the study, there was no significant difference on PSA response and median progression-free survival between the two groups, meaning the standard versus the low-dose enzalutamide group. Of course, as a caveat, we have to remember that this is a small study, and the follow-up period is relatively short, okay? And then another study published in the Journal of Clinical Oncology was done, this time in a developing country like ours, in the Caribbean, and had a similar study population as the one study I mentioned prior to this. So at 3 months follow-up, the standard and low-dose enzalutamide group had no significant difference in PSA results or PSA decline. Okay. Still another study from the UK. This time, what they did was they modified giving enzalutamide. So instead of continuous, they tried giving it intermittently. Okay, this was published in the Journal of Clinical Oncology too, so it's a reputable journal. So they included patients on treatment from 2011 to 2018, and those who were with significant side effects from the treatment were given 1 month break. So that's how they were able to come up with this review. And using Kaplan-Meier analysis, using enzalutamide intermittently, meaning giving breaks when they see side effects, did not appear to affect overall survival curves. So again, of course, this is a small retrospective study. But we have some data. So if you'll come to think of it, you might be able to consider it in your real life practice. Okay. And then finally, of course, the use of low-dose abiraterone. Somewhat, they have more data. They actually have a phase 2 trial from the US and Singapore to support this. Okay, the study randomized 36 patients each. So 36 to the standard dosing, and then which is the 1,000 milligram per day, and then 36 to the low dose, 250 milligrams with low-fat food. That's to improve its absorption. And then, of course, this was given with prednisone, 5 milligrams. And then the primary outcomes measured was the PSA change and progression-free survival, change in testosterone, as well as pharmacokinetics were other outcomes that were measured. These graphs show the PSA logs of the two different groups. The findings only show that low-dose abiraterone was non-inferior to the standard dose in terms of PSA metrics. Although again, of course, at the end of the conclusion, long-term follow-ups are needed. Larger RCTs, ideally multi-center, multinational, are ideal. So we can see the real picture or the real effect of comparing or giving low-dose abiraterone. Okay, so we need to establish this more. But there's some data. Okay, so the last hack I have, albeit still controversial, is that of adjusting the dose of novel agents added to ADT. So advantages, there are some studies already showing clinical benefit of these lower dose hormonal agents, potentially better side effect and toxicity profile since they are lower dose, cheaper because they'll need less medication, and because of the cheaper cost, this can also translate to better compliance for the patient. So sample calculations would be if you take the 250 milligram per tablet dose, for 1 month, that would only be 24,000 a month instead of the approximately 90,000 pesos a month with the standard dose. And then for enzalutamide, for example, instead of the 160 milligram, for example, if you give 80 milligrams per day, then that would cost 55,000 a month instead of the over 110,000 a month with the standard dose. So, these things we're looking at, worth considering. There's still lack of level 1 data, not yet enough science to back this. So you need to explain this to this patient. But so far from the small studies, from the initial reports that we're getting, there seems to be somehow comparable or acceptable oncologic results. Okay. So this is my last slide. This is the summary of the uro-oncology hacks we discussed. I am sure that each one would have his or her own little trick in urology practice. And I think that the beauty of it is we can learn from each other. So therefore, I look forward to learning from you as well. Okay? So once again, thank you to everyone. And salamat po, PUA Mindanao.
Our next speaker is a quintessence of a woman in the field of endocrinology. Breezed through BS Biology in UP Diliman, graduated magna cum laude, she finished her medical degree in UP College of Medicine, pursued internal medicine residency in Philippine General Hospital. She became chief resident and was awarded as most outstanding resident. Proceeded her fellowship in endocrinology in the same institution, also became chief fellow in her senior year. In 2002, she received Ramon Abarquez Most Outstanding Fellow. On the succeeding years, she unveiled superb practice not only in the field of endocrinology, but also in academe. She is currently a Professor 10 in UP College of Medicine and was the chair of and director of UP Manila Interactive Learning, Social Media Committee, and Medical Informatics Unit in UP College of Medicine. Last 2014, she received the Philippine College of Physicians Presidential Award for Social Media Advocacy, and in 2015 received University of the Philippines System Gawad Pangulo Award for Progressive Teaching and Learning. Her expertise won't also be denied to flow in the channels of social media. She is in the Hit 100 Most Influential People in the Health Informatics on Twitter. She also received Philippine Blogging Awards People's Choice Award and Philippine Blogging Awards Best Blog Post of the Year for her website. With thick list of co-authored publication and a modern influencer in this social media-driven world, this woman will continue to share her wisdom to the Filipino people. Let's welcome Dr. Iris Phil C. Isip Tan.
You did what? To whom? On what? Well, did you see a patient on a telemed platform and have a teleconsultation? Today we're going to talk about some tips on how you can do that. I've divided my presentation into 3 parts. First, choosing a telemedicine platform. What are the considerations? Second, what are some typical steps in a teleconsultation? And lastly, how do we keep it safe for all, for both the patient and the doctor? What I'm going to talk to you about today is all in the UP Medical Informatics Unit guidance documents. We have 5 articles in there, and they are at bit.ly/UPMIU Telemed 2020. So when you're choosing a platform, only you can figure out what is best for you. People often ask me, what do you use? Can you recommend something for me? But really, it's really dependent on the context. How do you intend to incorporate telemedicine into your practice? To what extent and what services will you offer via telemedicine? And how sustainable is a telemedicine practice for you? Is it something that you're only going to do during the pandemic? Then perhaps you shouldn't really invest so much on it. Or is it something that's going to continue in the post-pandemic scenario? And then when you're trying to choose a telemed platform, knowing your context, is it a freemium model, meaning the basic features will be available for free? Do you need those added features, and how willing are you to pay for them? Is it a subscription model? It doesn't matter if you use it once or not at all or many times, but you have to pay a certain monthly fee. Or do they exact service fees? For every patient that you see, the telemed platform will get something like 10 to 20% of your professional fee. And then we worry about the technology. Are you an image-intensive specialty? Would you require special camera or monitoring devices? What kind of microphone should we invest in? The software itself, does it have messaging functions? Because you know, sometimes the Wi-Fi is unreliable. Will it let you shift from a video to audio or just chat? What are the documentation features? Does it have, for example, a note-taking app? Or do you have to open your own EMR and put your documentation in there? How do they store and transmit the data? That is why the last is also about interoperability. If I had my own EMR already, and if I got a telemed platform that has its own EMR, then I will have the problem of reconciling the data between the 2 EMRs. And does it allow for customization? So I know, for example, that Some of the telemed platforms have virtual waiting rooms, and you're allowed to put your name on it or add some website to it that links to you, etc. So there are ways to customize. And then very important, we think about security and privacy because we do have to comply with the Data Privacy Act of 2012. So what are the telemed platform security practices? Where is their data center and what is their infrastructure practice? So I know, for example, that because of the controversy about Zoom before, now that there is a way to specify whether you want your data center in Zoom to be China or elsewhere. Restriction of health information access. Who gets to see the data? Because they are a third party that handles your telemedicine platform. That's why I know that some of them who follow the HIPAA regulation, they ask you to sign business associate agreements. And then disaster recovery measure of health information, especially now. So what happens? Where are the servers? Is it in the cloud? What happens when there's a disaster? Do you lose your data? And then you also think about customer service. Is there technical support for both physician and the patient? So I know of a telemed platform where they have flyers for instruction, not only for the doctors, but also for the patients. And then do they have a content program that offers news and information about the best practices even after launch? So sometimes they will roll out new features and then you wonder about them, and there's a community around the telemed platform so you can read about their experiences, or you can go to the forum and ask a question if you can't figure out something. Usability, very important. How does it fit in the workflow? So I know of doctors who have two screens that are open because one is going to be for the telemed platform and then the other one is going to be for the EMR. So is that something that you can handle confidently? Is it too complex to use? So there are certain telemed platforms where there's a separate app for the physician and then a separate app for the patients, and that can sometimes get confusing if they get the wrong app. Is the interface user-friendly? Remember, some of our patients are elderly or they're not so high-tech, so they need the interface to be simple. Are there billing features? So do I ask for my PF separately from the platform, or does the platform do it for me? But if the platform does it for me, when do I get my professional fees? Is it like twice a month on the 15th and the 30th? How does it get transferred to my account, etc.? You have to ask the accountant, do they issue receipts? What happens to the tax, etc.? So the next would be the steps in a teleconsultation. What are the sequence of events? So first, you need to set up. So what are the minimum requirements to set up for telemedicine? Well, you need a communication device. And it can be the landline, it can be a mobile phone with or without camera, and a computer. And of course, if you're using video or chat software, you need to have a stable internet connection or else you're gonna end up shopping. A private well-lit location is preferred, especially if you're gonna have a video consult. So how fast should your internet be? A minimum of 2 Mbps per user so that you can get HD 720p video at 30 frames per second. You need a private, quiet, well-lit room. You need to have a comfortable seat, especially if you're going to see patients for a long time. At least when we're in the clinic, we usually stand up, right, in between because we're going to do like a physical exam. You need a secure table platform because if you're like me, my laptop is perched on a bunch of books so that I will be at eye level with its camera. So sometimes, you know, it might fall. So we want a secure table platform. White light, not incandescent. We certainly do not want yellow light, especially for the patients because they may appear jaundiced even when they're not. A single color background, and if you're gonna paint the wall where you're gonna have your teleconsults, they were saying it should be light blue, flat latex paint so that there's no glare. And try to eliminate echo. Are you gonna wear your white coat? Well, some of our patients prefer that, but keep in mind that white coats and light colors can increase reflection in there. Even now you can see that there's a reflection of my laptop on my glasses, for example. Angle and vantage point might emphasize bad posture or fidgeting, so please be aware that you are on camera. Look at the patient so that you might need to disable the picture-in-picture. So right now I'm using Zoom to record, and if I look at my picture, I will not be looking at the camera. So if this were a teleconsult, I would not be looking at the patient, that the patient might feel that I'm not concentrating. You may or may not wear headsets for privacy. The recommendation is, if you can, do not wear headsets so that we mimic the usual face-to-face encounter in the clinic. But for some, it might be impossible. We need to ensure privacy, so we don't want the conversation to be heard, so maybe we need to wear the headphones. Now, before the teleconsultation, I've already talked to you about the setup, the technical and room requirements, but we also need to select the patient because remember, we cannot see emergencies via teleconsultations. And for your particular specialty, you might need to decide which sort of patients are appropriate. You need to prepare previous records because documentation is important. As a personal experience, I could not access my electronic medical records from the house. They would not allow me even through a VPN. So I had problems about my records. You have to check the connection. In telemedicine setups elsewhere, a nurse or the secretary actually schedules a tech rehearsal with the patient. So they call up the patient maybe a few days before and check the audio, the video connection, etc. But also when you log in, you need to do that again. So you have to ask the patient, can you hear me well? Can you see me well? Before you launch into the actual consultation proper. If there are other people in the room, you have to give introductions. So if there's someone with the patient and you don't know who they are, or if there's someone with you, maybe a resident assisting, for example, you need to have introductions. And of course, you need to secure consent. And I will show you later our template from the medical informatics unit. During the consultation, you need to determine the agenda because you need to agree on what will be discussed. Because we have a limited time and you know that the Wi-Fi might go off or out anytime. So we really need to schedule. For my particular clinic practice, the patients are informed that patients are scheduled at 30-minute blocks and that they have to log in 15 minutes before. And I do ask them to come up with their 3 questions that they want to be discussed during the teleconsultation. You have to explain the process, what is needed for diagnosis and treatment, because there are limitations. So for example, while doing the history and PE, I think it will just be a typical diabetes follow-up, and then the patient suddenly says, I have abdominal pain, but you know I cannot examine the abdomen through the webcam, so I'll have to explain to the patient what we're going to do about that. So either I'm going to refer the patient for an actual face-to-face consult, or we'll do a laboratory exam, etc. It's also important to get patient feedback during the consultation. So check in, was that clear? That wasn't choppy, did you get that? Because sometimes you get choppy, but they're too polite to let you know that they lost some part of the conversation. After the teleconsult, please summarize for the patient so there will be opportunities for clarifications, as I said, because there may have been some technical glitches. You have to explain the plan, including like what lab requests they need to do next and what are the prescriptions. Arrange your follow-up and give instructions. What are the red flags? If you feel this or see this, you might need to go to the ER. Our face-to-face consult will be delayed because of the pandemic, but we can do another teleconsultation at so-and-so month, and I need you to do the following labs. And then end the visit by thanking the patient and eliciting feedback. So is this something you want to do again? Because we don't know when the pandemic is going to end. So if I follow up at 3 months and it's still like this, will that be okay? So surprisingly, the younger patients prefer telemedicine or teleconsultations, but the older patients, even though they say it's convenient, they prefer still the face-to-face. I don't know how it's going to be for your practice. After the teleconsultation, well, you're not done yet, because if you're like me, you need to complete the documentation because it's hard to be typing while seeing the patient. So generally, I just type short phrases or words, and then I complete my documentation after I've said goodbye to the patient. And then I email them a summary and the prescription, and some people prefer to use password protection for their emails. I know that Gmail allows you to password protect. So how do we keep the teleconsultation safe for all, both the patient and the physician? So first, when we go into a teleconsultation, we have to verify identity because a teleconsultation cannot be done anonymously. You know, it's easy when you have video and it's an old patient, right? But what if it's only chat? Or even if it's an audio call? How do I know that I'm talking to the right person? And more so for the patient, how does he or she know that he's really talking to a real doctor and not someone pretending to be a doctor? To protect confidentiality, we must obtain informed consent, and that is in compliance with the Data Privacy Act of 2012. And it has to be evidenced by written, electronic, or recorded means because implied consent is not recognized by the National Privacy Commission. And so the consent must be freely given, specific, and informed indication of will, whereby the data subject agrees to the collection and processing of personal information. And we have a consent template at the UP Medical Informatics Unit link that I have shown here, both in Filipino and in English. One feedback we have received is that it is too long because it is 3 pages. But the reason why it's very long is because it has the following parts: the introduction and purpose, the nature of the telemedicine consultation, the benefits, the potential risks, data privacy and confidentiality issues, and the rights and limitations. And this is just a partial screenshot because, as I said, it's 3 pages long. If you will record the teleconsultation, and I strongly advise you not to, there's a separate consent form. And why do I strongly advise you not to record the teleconsultation? Well, because it will be just like the data we have in the EMR or in the paper hospital charts, where you have to protect the data for at least 15 years, diba? Do not destroy the data, and then if there's a data breach, then you will be responsible for that. That's why it says here, I will do my best to keep it safe from theft, corruption, loss, illegal use, or sharing on social media. So we do have a sample documentation template. So why do we say this is a safe practice? Well, beyond what we usually write in our electronic medical records, there are some things that are specific to teleconsultation. So the reason why it's a teleconsultation, so we'll say, well, there's a quarantine, the patient cannot come to the clinic, that's why we're having a teleconsultation instead. Document that consent has been gotten, where am I seeing the patient from, where is the patient, what are the limitations of the visit, if any. So the example I gave earlier was not being able to do an abdominal exam. The other limitation might be technological, like for example, in the middle, the Wi-Fi became so bad that I had to shift from video to audio, or I had to shift from audio to chat, and that's why, you know, we were not able to do some things. You may have to write not only the date and time, but also the duration of the teleconsultation. We don't know when or if the PhilHealth will reimburse teleconsultations, but abroad, the model has been, they reimburse according to the duration. So I think we need to put that there. And then the attendees present, were their caregiver, relatives present. So, you know, just in case there's a question that arises later on, we know who was there and who can serve as witness to what actually transpired in the teleconsultation. We need to encourage feedback and monitor outcomes because we're all new to this. Is it something that the patient might want to do again? Is there ease in scheduling of appointments? Is the teleconsultation feasible or convenient? How satisfied is the patient with the service? And even beyond that, maybe clinical outcomes. Was it safe to have deferred the face-to-face and have done a teleconsultation? Was it better overall? And then we have the e-prescription, and it's so good that the FDA issued a circular, but then it's only during the time of the pandemic. So we're hoping that if telemedicine will continue in the post-pandemic scenario, they will have more enduring legislation about this. But basically in that circular, they said the e-prescription is optical electronic data, which is the same as the prescription and can be sent online, okay? Please keep a copy of the e-prescription in the patient's medical records. So why do we send a teleconsultation summary? And I mentioned it here as a safety feature. Why? Because for transparency, it allows for the correction of discrepancies and misinterpretation. So you can clearly say, this is what I told you, and I sent it to you, and you didn't ask any questions or clarifications. So I assume that you understood it, right? It will be an opportunity if the patient does have questions. Oh, but doctor, I thought you said that the dose will not be the same, it will increase. However, in your notes, you said continue the same. So now I'm confused. What do I need to do? So it's really that That's the safety part, allowing for correction of discrepancies and misinterpretation. And then helpful reminders like when do we need the test to be done, where are the referrals, does the patient need to go see another doctor, etc. That's the end of my presentation. Very short, but I hope very impactful and helpful to you as well. If you'd like to contact me, I'm on Twitter and there's my email. And again, to share the link to the Medical Informatics Unit guidance documents on telemedicine, it's bit.ly/UPMIU Telemed 2020. Thank you.
Our next speaker is a fellow of Philippine Urological Association. Dr. Fidel finished his medical education in the University of Santo Tomas in España. He had his general urology training in East Avenue Medical Center, wherein he published and presented several research papers locally and an international urology. Also, while in training, he developed the first software application for mobile phones made by a urologist and made for urologists, which he named Hematuria Meter application. This application was recognized and was presented in the podium in the Urological Association of Asia Congress in Singapore and in the Functional Urology Symposium, Pan-Pacific Continence Society annual meeting, which was held in Sydney, Australia. He is a diplomate of the Philippine Board of Urology and recently a fellow of the Philippine Urological Association, after which he decided to undergo clinical fellowship training in Yonsei University Severance Hospital in Seoul, South Korea, for female functional urology and neurourology for a year under Professor Jang Wan Kim. Simultaneously, he underwent minimally invasive uro-oncologic fellowship training under Professor Kunho Ra. Currently, he is a visiting consultant in East Avenue Medical Center and Fatima University Medical Center and an active consultant at the National Center for Mental Health in Mandaluyong City. Let us all welcome our next speaker, Dr. Fidel Manalaysay III.
Hello, good afternoon. I'm Dr. Fidel Tomas M. Manalaysay III, and my lecture is about hacks in female urology. So what's female urology? Female urology encompasses urinary incontinence as well as pelvic reconstructive medicine for prolapse. It deals with assessment and treatment of female urological disorders like interstitial cystitis or stress urinary incontinence. The bigger term will be functional urology. It's an overlap between female urology, reconstructive urology, and neurourology. So this is me during my training in South Korea. This is me assisting a pubovaginal sling procedure, an augmentation ileocystoplasty procedure for a resistant interstitial cystitis. And this is my professor, Professor Jang Wan Kim of Severance Hospital in Seoul, South Korea. After my 1 year of training, we had a total of 180 cases, majority of which are laser enucleation of the prostate, sling procedure, and prosthetic artificial sphincter. So for my lecture, I'll be starting with anatomy, followed by evaluation, discussion of female SUI, and then management. We already know that the female pelvis has a bigger inlet than male pelvis. Its shape is wide and round, while in the male, it is said to be heart-shaped and narrow. Also, the pubic arc in the female is wider. This is around more than 80 degrees, while in male is usually narrow, less than 70 degrees. The bigger structures and anatomy in the female helps in accommodating the baby in the normal spontaneous delivery. This is a lateral view of the female pelvis, which shows the relationship of the urogenital organs and the reproductive organs. Other relevant structures in this diagram are pubourethral ligament, which is this one, the uterosacral ligament, this one, pubocervical fascia, and the rectovaginal fascia. According to Petros et al., the integral theory talks about continence, and the most important factors to preserve continence were adequate function of the following: the pubourethral ligament, a suburethral vaginal hammock, and the pubococcygeal muscles. Active closure includes contraction forward of the pubococcygeal muscles, which plus the vagina tightly around the urethra. Closing it off and immobilizing it while the bladder is pulled down like an elastic balloon. Kicking off and closing off the mid-urethra. So during micturition, the pubococcygeal muscle relaxes like this. This allows the levator plate and the longitudinal muscle of the anus to uninhibitedly pull and opening the bladder base. This is like a funnel, enlarging the urethral outlet. At the same time, this stretching stimulates the nerve endings, activating and reinforcing the micturition reflex. We're going to the second part of our lecture, which is evaluation. It is very important, way back from med school, that history and physical examination is the most important part of the assessment. We should know what's the chief complaint of the patient, which is the most bothersome complaint, and the reason why the patient went to the hospital or the clinic. After which, we determine the history of present illness, specifically eliciting presence of frequency, urgency urinary incontinence, or necturia. In the past medical history, it's important to ask the patient about comorbidities and medications which may affect our present illness and the complaint of the patient. Also, previous history is important to determine if there's a previous link procedure or previous incontinence procedure. So what unique in the female is or are presence of urethral mass, which can be a prolapse or caruncle, vaginal changes like atrophy, discharge, lesions, bulging mass, and we should always elicit an OB or menstrual history. Some tools that can help in the diagnostic process, first of which is bladder diary. This is an example of bladder diary. I extracted this diagram from the latest edition of Campbell. Bladder diary is said to be the best non-invasive tool, which can document the number of episodes of leaking, the number of pads, times the patient is passing urine, average and maximum voided volume, types and amount of fluid drunk, and presence of urgency and nocturia. Bladder diary has a self-monitoring effect, which means it enhances patient awareness of drinking and voiding habits, which makes them recognize how their lower urinary tract symptoms may be related to their activities. It is recommended and appropriate to record at least for 3 days, according to the International Continence Society. So this is an example of a bladder diary, a 72-hour bladder chart, specifically or by from the recent lecture by Dr. David Bolong. He also emphasizes the importance of taking a bladder diary. Another tool which can help us in the diagnostic process are questionnaires. So what are questionnaires? These are validated set of questions that can measure the severity of a symptom of interest. Example which are IPSS or International Prostate Symptom Score, ICIQ or International Consultation Incontinence Questionnaire, OAB Overactive Bladder Symptom Score, and SANVIC. Different questionnaires ascertains different symptoms. So if you notice, one of the questionnaire here is in Korean. I obtained this from our outpatient clinic in Korea while I'm studying there. So you wonder, how can I understand this? I use Google Translate application for this type of, in the outpatient in assessing the questionnaires. We usually use this before we start the history taking. So in the part of physical examination, when the patient came in our clinic, it's very important to record the vital signs. After which we get the height and weight, and we compute for BMI by dividing the weight of the patient in kilograms by meter squared. And then, followed by, we check the head and neck, the chest and the heart, abdominal back, extremities, and digital rectal exam. And what particular or what specific unique in the female will be the pelvic examination. So this is me doing the physical examination of a female patient. I showed this picture to show the importance that when you're a male doctor or a male nurse and you're examining a female patient, you should always be accompanied by a female nurse. So for my first question to the audience, what are the components of a focused pelvic examination? Is it A, breast exam, internal examination, speculum exam? Is it B, digital rectal exam, i.e. speculum? Is it C, IE and speculum? Or is it D, breast exam, DRE, IE and speculum? The answer is D. So how do you do a pelvic exam? First, we ask the patient to lie down, and then we examine the external genitalia. And then thirdly, we use a lubricated speculum and inspect the vaginal walls and the cervix. And lastly, we do an internal examination with the use of a gloved finger, inserted and check for the uterus and ovaries. So according to Campbell, the components of a focused pelvic exam are the following. Start with breast exam, digital rectal exam, pelvic exam proper, which includes external genitalia, urethral meatus, urethra, bladder, vagina, cervix, uterus, adnexa and or parametria, anus, and perineum. According to this table, 7 out of 11 bullets listed are required to consider complete female genitourinary examination. So in the clinic, if you're examining a female patient, what are the things that you need to do it? First, you need a speculum of different sizes, an examination table with drop light for visual purposes, gloves, lubricating jelly and alcohol, and cotton balls, cotton pledgets, swabs, povidone iodine, syringe, lidocaine, sterile water, and some tape. So during pelvic exam, what are the pertinent findings to look for? If the patient has urethral mass, we should differentiate either caruncle, which is this one, or a prolapse. The difference between a caruncle and a prolapse: caruncle has a one-sided protrusion, usually the posterior wall of the urethra. While in the caruncle, it's usually circumferential. The whole part of the urethra is outside. And of course, if there's a mass in the urethra, we should always rule out for presence of tumor. Another pertinent finding is presence of vaginal or vulvar atrophy. So what do you see in a patient with atrophy? Some loss of labial vulvar fullness, there's pallor, the introitus are narrow, there's minimal vaginal moisture, and there's loss of urethral meatal turgor. Other findings will be pelvic organ prolapse. It can be either uterine prolapse, a cystocele when the bladder is prolapsing, or a rectocele when part of the small bowels, or large bowels, are prolapsing. So this is a diagram showing how does the coronavirus infects or invades a normal cell. But I will not elaborate on this. With regards to this, EU guidelines released a recent recommendation, and the recommendation are the following. If capacity allows, remote consultation can proceed utilizing all the current recommendation. Symptom score and bladder diaries can be emailed to the patient. Urodynamic evaluation should be deferred. Imaging is not recommended for evaluation of patients with urinary incontinence. If capacity allows, resources from primary care can be used for monitoring or blood tests. Remote follow-up existing patients is recommended only if capacity allows. So this is Professor Marcus Drake from a recent webinar I have attended. So what's the impact of COVID to my urological practice? In the outpatient, we use this particular screen, and then I wear a double mask, surgical mask over N95, and I usually wear a face shield. And this is the patient. While in the operating room, usually I wear full PPE or personal protective equipment, which is composed of coveralls, goggles, respirator mask, double gloves, some leggings inside, and then shoe cover. Also, with regards to the recent pandemic, I've done some telemedicine and teleconsult using the Sears MD application. We go now to the third part of our lecture, which will be female SUI. So some female urological disorders that are common are urinary incontinence, stress, urgency, or mixed incontinence, overactive bladder syndrome or OAB, pelvic organ prolapse, and vesicovaginal fistula. With regards to urinary incontinence, according to the ICS, it's defined as involuntary loss of urine, and we can differentiate it either stress incontinence, urgency incontinence, or mixed incontinence. Stress incontinence is incontinence associated with effort or exertion, or sneezing or coughing, while urgency incontinence have a feeling with a sudden compelling desire to pass urine, which is difficult to defer, and mixed in a combination of stress and urgency urinary incontinence. So in the interest of time, and since the prevalence of stress incontinence is higher than mixed and urgency urinary incontinence, we'll be focusing with stress incontinence, particularly in females. So how do you diagnose stress urinary incontinence? The most important part will be history. Again, the history. Because SUI or stress urinary incontinence is a clinical diagnosis, the history of involuntary loss of urine on effort or exertion or sneezing or coughing is most important. Will be supplemented by the pad test and the Q-tip, which I'll be discussing later. And then other tests, urodynamic is optional. It is accepted worldwide that we should not request for urodynamic study for patients with simple and pure stress urgency incontinence or urgency, pure stress urinary incontinence patients. Focusing on history, we should know what are the risk factors for stress urinary incontinence. According to the study by Price et al., the risk factors are pregnancy, vaginal delivery, obesity, high-impact sports, chronic respiratory disorders, intra-abdominal mass, use of diuretics, presence of diabetes mellitus, neuropathies, dementia, and smoking. So pap test is a simple test that we can do in our clinic. So how do we do it? It is used to quantify the amount of leakage. It can be either 24-hour or 1 hour. In a 1-hour procedure, the significant or severe incontinence can be defined as more than 50 ml, while in a 24-hour pad test, it is more than 5 pads per day according to the AUA. Also, a supplementary test is a Q-tip or cotton swab or applicator test. So how do we do this? This is used to evaluate urethral mobility, and the urethra is said to be hypermobile if it's more than 30 degrees from the horizontal. So this is the diagram how to do it. This is normal, and this is patients with stress urinary incontinence. As we can see in this diagram, it is more than 30 degrees. So how can we measure it? By the use of a protractor. Moving on, urodynamic study is an optional test, and it is a dynamic study of transport, storage, and evacuation of urine. Its indications are the following: if there prior SUI surgery, if the diagnosis is uncertain, or there's inability to demonstrate SUI on physical examination, if there's a history of pelvic radiation, if the presence of neurological disease, and the patients have very severe symptoms. It's also indicated in patients who are considered for surgical corrections who has or who have mixed symptoms or emptying difficulties. So from the recent lecture by Dr. David Bolong, he showed this diagram of a mano-mano or a poor man's urodynamic. It is also known as the eyeball urodynamic study. In the setting that the urodynamic machine is not available, it is a simple, economical, and a favorable alternative to the full multi-channel urodynamic study, which uses two small catheters, this one and this one of which is connected to a catheter filled with sterile saline, and the other one is connected to a manometer. This can determine bladder sensation, compliance, stability, capacity, outlet competence, and post-void residual. The limitation of which is there's an absence of measuring of abdominal pressure, which limits the ability to accurately determine any abdominal contribution to a change in water volume in syringe. So for my second question to the audience, so what's the aim of a urodynamic study? Is it A, to diagnose a disease? Is it B, help the clinician when to refer? C, in the presence of complicated case? Or D, to reproduce symptoms while making precise measurements? The answer is D. This flowchart I obtained from Campbell. I just want to show you this flowchart to focus on this part. We know that a patient has a complicated urinary incontinence if it's recurrent, if the incontinence is associated with the following: pain, hematuria, recurrent infection, if the patient has voiding symptoms, with history of pelvic radiation or history of radical pelvic surgery on a patient or in a patient with suspected fistula. In this type of cases, we should advise the patient for consultation to a specialist, because the specialist might do a ureterocystoscopy or imaging or urodynamic study. According to the EAU guidelines, in a female patients with urinary incontinence, can be either stress, urgency, or mixed incontinence, it is strongly recommended that we should do in the initial assessment history, physical examination, questionnaires, voiding diary. We should request for urinalysis to rule out infection. Also, we should do post-void residual if there's voiding difficulty. After which, we discuss management options to the patient, and then we differentiate patient either with stress, mix, or urgency incontinence. But regardless which stress, mix, or urgency incontinence, it is strongly recommended that we should start behavioral treatment and pelvic floor, that includes pelvic floor muscle training. So in the management, particularly of stress urinary incontinence, the management option can be divided into two. First of which is conservative and then surgical. Under conservative is behavioral management. Under behavioral management is patient education and pelvic floor exercise or muscle training. In a surgical, we can do either a bulking agent procedure or sling procedure, pulpo suspension, or artificial urinary sphincter. What's behavioral management? It's usually the first line treatment for patients with urinary incontinence. Why? Because it's virtually risk-free. It's a group of interventions that improve lower urinary tract symptoms by changing patients' behavior or environment or by teaching new skills. Some of which includes patient education with self-monitoring like bladder diary, fluid management. It is advised to advise the patient to decrease fluid intake by 25%, provided that the baseline consumption is not less than 30 ml per kilogram per day. Caffeine reduction. It is said that 2 cups of coffee is equivalent to 250 milligrams of caffeine and is associated with urinary incontinence. Dietary changes. Increase fiber. We should advise the patient to increase fiber in the diet because chronic straining due to constipation may be a risk factor for urinary incontinence. Weight loss. around 5%, the odds of developing urinary incontinence at 1 year can be reduced by 3% for every kilogram lost. And then lifestyle changes, particularly for smoking, because smoking increases the risk of more severe urinary incontinence. So moving on, under behavioral treatment will be pelvic floor muscle training. It is said to be the cornerstone of behavioral treatment. And currently, there's no ideal regimen yet, although there are many sets of exercise available in the internet, and protocol varies from center to center. Do you recognize this man? This is Arnold Henry Kegel. He is the one who coined the term, or who invented the Kegel exercise. He is an American gynecologist who proved the efficacy of pelvic floor exercise for recovering strength of pelvic floor muscles, hence the name Kegel exercises. The first step in patient with advice for Kegel exercise is to teach the patient how to identify the pelvic floor muscles. So how do you do it? You insert your two fingers inside the vagina and ask the patient to contract the muscles around the finger and try to pull up and in. According to the UCLA, we can advise the patient to do 15 contractions per set, and you should advise the patient to hold it for at least 5 to 10 seconds and to do it to 3 sets per day. However, Kegel exercises can just be worth it if the patient have a good motivation. Also, advising patient to do Kegel exercise, you should always observe the patient and you should tell them they should not strain down or perform Valsalva or use accessory muscles, because this will just exacerbate the urinary incontinence, and it will not help them to relieve the urinary incontinence. So for my take-home message in this lecture, there's no good substitute for good history and physical examination. As we know in med school, history and physical examination is still the most important part in the assessment of patients, even for other sickness other than urinary incontinence. But in female patients, it's important to include a good pelvic examination, as I discussed a while ago. And then additional supplemental tests like bladder diary and questionnaires can help us in the assessment. Conservative treatment should be offered first to all patients with urinary incontinence, under which are behavioral, like patient education, and pelvic floor muscle training or pelvic floor muscle exercise. And then lastly, if there's a failure of conservative treatment, or if there's presence of complicated urinary incontinence, we should always refer to the specialist, because they know the best and they can do what's best for the patient. Yeah. So this is Donsei Severance Hospital, where I train. So it's the end of my lecture. Thank you for your kind attention. You can follow me on my Facebook page, Urology Consult Online PH. Any questions?
Our next speaker is a professor of urology, Faculty of Medicine, Mohammed B. Rabat, Morocco. He is a voluntary consultant on the Department of Urology, Al Ghassani Hospital, FES, and the current chairman of the Symposium on Affordable New Technologies in Urology, SANTU. He was the past chairman of the Department of Urology, Military Hospital Moulay Ismail, Meknes, Morocco, and is the pioneer and instrumental in the revival of endourology in Morocco. He has special expertise in endourology, PCNL, with development of proper techniques, PCNL in the split leg modified lateral position, needle renal displacement technique, percutaneous endopyeloplasty, and endoscopic suturing technique. He developed many simulation models, namely glove models for puncture, endourologic stone manipulation, TURP model with sheep kidney, nephron sparing model with a veal kidney. He also has many tips and tricks and innovation of affordable urology. He does voluntary work promoting endourology and minimally invasive surgery in Morocco, coaching young urologists in Morocco since February 2011. He has many national and international PCNL live surgeries, courses, or hands-on training. He's a member of Global Urology Collaborative, https intersurgeon.org clinicals_offer 1649, and has more than 120 videos of tips and tricks of endourology in his YouTube channel, https www.youtube.com/Lazrek Mohammed. Let us all welcome, friends, our colleague, Dr. Mohammed Lazrek.
Hi, greetings from Morocco. First, I want to thank the organizer for inviting me to this course, and it is a real pleasure and honor for me to be among the faculties of this course and share with you my experience of hacks and tips and tricks in endourology. First, I have no disclosure to do. But before we start, I want to invite you to submit your works, your ideas to SANTU, which is a symposium on affordable new technologies in urology, which is held the first day of SIU. And there is also a competition that called Bantuk for the best affordable new device. And I am the chairman of SANTU for this last few years. And I'll be happy to have someone, a few winner of a prize. Here are the photos or some of the winners of the previous years. And you will find the rules on the SIU website. So I was the head of the Department of Urology in the Military Hospital Meknes, Morocco. Meknes is a city in the center of Morocco. And we were promoting endourology and especially PCNL. We have done a revival in Morocco in the region of Meknes in the center of Morocco. And since 2011, I am doing almost full-time voluntary work, sharing through social media, but also coaching actively and supervising their training, small groups of urologists, especially in government hospital or public hospitals, and some friends on private hospitals. So I have done a lot of workshops, and I am still doing them in Morocco, but also in Africa, Senegal, Johannesburg, Douala, La Cameroon, in Tunisia, and so on. So this is just to tell you that most of the ideas and tips and tricks that I will show you are teamwork. So these are ideas gathered through and by interacting and brainstorming with many friends and colleagues. So why are we looking for hacks, tips and tricks and cheap solutions? You know, developed countries had an organized and trusted system with availability of everything, almost everything. However, this is not true for all the people all the time. So things are not available because there is lack of money, there is mostly poor organization, and also mostly administrative hassle and slow motion of administration. So what do we do to have these hacks and cheap alternative? We have to be ingenious, open-minded. We have to optimize what we have in hand. And also, especially, don't forget that cheap resources aren't just objects or devices. So we can have an idea, we can optimize what we have at hand and have a good organization and communication. Also, don't reinvent the wheel. Now we have most of the techniques and variation and tips and tricks are on the net freely, mostly on YouTube and social media. Also, we have to use things in unconventional way, to think out of the box, but we have to do it in intelligent way, not to skip an important step in the technique to gain time. Also, we have to share what we discover, what the tips that we have. We have to teach and coach and share our resources. And by sharing, mostly we receive and we learn more. And also we have to be humble and to be open-minded and to listen to the other. Sometimes someone less expert than you might give you an idea, or a nurse, or... And also we have to do this creativity. I think all human beings have this creativity. Like, for example, in our daily life, we might use a knife as a screwdriver. We just have to use this creativity in our work. But not only humans, also animals. Here is a bird fishing with small bread. Also, killer whale hunting birds with a fish. Also, an otter opening clamfish by stone on her belly. So I will try to give you some examples in our practice, in our experience. But also, practice makes perfect. By thinking innovation and share it with people, you will do more creativity and more research. So you know very well, necessity is the mother of all invention. So just an idea, it is the cheapest way of innovation. We have to learn from history. So mostly, you know, the first steps are percutaneous renal surgery, reported in 1941. Ripper and Brown had described a nephroscopy through surgical nephrostomy tract previously done already in 1941 using a cystoscope, and also the great work of Frenstrom and Johansson, who had pushed forward PCNL by using just a forceps through a nephrostomy tract. So what can we learn from history? So both these people didn't have no technology or special equipment. It was not NASA. They just had an idea. This is creative thinking. And also they have the idea and they had the courage to use their idea. They weren't ashamed. And they had used their equipment in a different indication. So they had maximized what they had available. And also they had shared their idea by publishing the article. So if we just follow this few or couple of rules, we can do like them, and we can have a lot of tips and tricks and being creative. And nowadays, we have a great opportunity by using social media, and I will give you an example. So I was helping friend doing rigid ureteroscopy. Suddenly the ballistic probe broke, and we didn't have a spare. We cannot do soldering or welding. So what we have to do? We have to stop the procedure, or we have to find another way. So I was lucky. Just in the entering the operating room, they were doing some metal work on some lockers, and there was this metallic rivet, and I thought this is similar to the tip or the proximal tip of this ballistic probe, and we have done it, and we have continued the procedure. And the beauty of it, so I just share it on LinkedIn, and few hours after, I have another idea. And you see here, my friend Heron had said that they were using bicycle spoke. So this is the beauty of social media. By just giving an idea, and I had received an idea back without paying anything. So when you have an idea, you always try to push it forward to find another extension of this idea. So how we begin a ballistic probe from scratch, how we have this shaft, what can we use as a ballistic probe for the ureteroscope? So we can use a stainless steel body guide wire, or even the hydrophilic guide wires, especially stiff hydrophilic guide wire. We can peel the plastic sheath and we can use the shaft, and we have done it and it worked. So now we have the shaft, we have the proximal tip, but we need this small rubber segment. It is mandatory to have the handle of the ballistic probe working. So we can have this small rubber seal from a Foley catheter. And it is working just fine. This is a probe totally handmade. So what is the cheapest safety guide wire insertion? So in percutaneous surgery, I always advise to put a safety guide wire. The most used tip is we use a small segment of the coil housing the guide wire. And here we see the dilation of the tracts. Then introduction of this segment, and we see the safety guide wire inserted. Of course, we use a small French 8 or 9 French housing coils. The 12 French will be difficult, so we have to do 2 French dilation to 2 French above. Another way to do it, through the Omplatz dilator beside the metallic rod, but we have to remove the dilator, then continued dilation beside the guide wire. Another way to do it, by doing a hole into a fascial dilator, introducing the safety guide wire, then the fascial dilator is pushed over the working guide wire. When we reach the pulocalyceal system, the guide wire is dislodged and it is coiled into the pelvicalyceal system. But we can use also an 8 or 10 French feeding tube or aspiration tube or a large WG stent pusher. But nowadays, mostly in percutaneous surgery, I use this tip that I took from the ureteral access sheet. So slit is performed on ureteral catheter and the guide wire is inserted just through this part with slit. By pushing the dilator, the guide wire is dislodged. So here in the patient, introduction of this WG pusher, the guide wire is stored in its housing coil. So we do dilation over only the catheter without guide wire. So the dilation is parallel or beside the guide wire. Of course, we have to use a stiff WG pusher or ureteral catheter. So we do a one-step dilator, and at the end of the procedure, the guide wire is outside on plastic sheet. Following the same idea, what is the cheapest way to insert a retrograde guide wire? We don't need the coaxial or double lumen catheter, just cystoscope. If we have 2 channels, we can put a guide wire through each channel. But even with 1 channel, after insertion of the first guide wire, then ureteral catheter is passed beside and the safety guide is passed beside the other guide wire. With the same thinking, we can use a segment of the housing coil housing the guide wire, or an 8 or 10 French aspiration tube. Let there be light. So I was about to do a PCNL with a friend, but our nephroscope was lacking this light adapter. We didn't have it. So what to do? We tried to take it from another scope, but impossible. It wasn't working. So we had this idea to take a small segment from a Foley catheter and to put it instead of the adapter. And it worked very well. We have the whole procedure was done like this. So how do we learn calyceal puncture? We cannot have virtual simulator, and also the biologic models are difficult to have in Morocco, especially on porcine kidney. So we had the idea to use a glove which is filled with saline, and we use the tip of the glove like the calyx. So it is inserted into a foam. However, this is a good model for puncture, not for dilation, but it has its limitation. It needs the C-arm and radiation exposure. So it limits the practice and to use it in a meeting room. So I was thinking for months how to do it with only light. And I was taking advices from friends, and I will show you how the availability of device give you the idea. So back in 2012, I was in a workshop in the university hospital in Marrakesh, and they had this retroprojector in the classroom. So one of the urologists suggested, this is a powerful light, you can use it. So the globe is filled with air, and we can do it by projection on the wall or just on a paper. Also, the absence of a device can push you toward another idea. So few weeks after I was in a private hospital, they didn't have this retroprojector. So we were searching for a source of light, and I had this idea to use the smartphone torch application. We can also shorten the fingers to have a more realistic or visible. We like hydronephrosis. So every time you have the idea, I showed you that you have to push it forward. And so if you are working and suddenly the endoscopic light source stop or is not available, what will you do? So you use this torch application of a smartphone, and you can do the procedure. Here is how we do it, and you see it is acceptable to do a cystoscopy and insertion of a ureteral catheter. And this is also, I will show you the interest of brainstorming and sharing idea. So I was 2 times in Dakar in 2017 and 2018, and I met a great man. His name is Dr. Graham Watson. He's doing volunteer work in Africa and Asia, and we were talking about if suddenly the equipment stopped, what would you do? So I told him this idea about other things that we had discussed. And if you know you need camera, you can use the smartphone and also the light. And few days after, I returned to Morocco and I received this email from him. He said, "Was it you, Mohammed, who said that you could use a phone to act as a light source?" It worked. So he was able to do the whole procedure. He was in Edward Francis Small Teaching Hospital in Banjul, the Gambia, with Dr. Abu Bakr Jah, and they done the whole procedure like this, the retrograde insertion and the whole supine PCNL. So what do we learn from this? So this is the benefit of brainstorming and sharing idea. Also, Dr. Graham, even with his age and his experience and is well known, and he had more experience than me, he has listened to what I said, and he had heeded, and also when the occasion presented itself, he had used what he had learned. So this is a great way. And we can push the idea forward. If also you don't have a smartphone, you can use the operating room light, and it works for small WG removal or just cystoscopy or insertion of a retrograde insertion of ureteral catheter. And also discussing with Graham, he is now doing more and more ultrasound calyx sphincter, but how to control the tract dilation. So I told him that I was doing since 2004 mini PCNL for second or third tract using the rigid ureteroscope. So after insertion to guide wire, the rigid ureteroscope progresses in the retroperitoneum until reaching the calyceal stone, which is pushed into the renal pelvis and extracted by the first tract. So, and also in SIU Lisbon 2017, a winning award video from Dr. Arvind Shah from Nepal. He uses a transparent unplugged dilator with the rigid ureteroscope or small nephroscope, and the wall dilation is done under direct vision. So it is a very good idea. So we can mix those two ideas, even if we don't have a transparent unplugged dilator. Here is an 8 French or 7 French rigid ureteroscope inserted through the unplugged dilator, and we can follow the guide wire like this and do the dilation under direct vision. So a friend called me for a removal of a double G stent in a 10 years old boy with the rigid ureteroscope. His removal forceps has broken, and with the tip, he cannot find the tip of the double G stent with the basket. So what is the solution? So on the spot, we had the idea to take the membrane stillate of a ureteral catheter and to do it like a hook, to shape it like a hook. And this way we can remove the double stent even from its body. So here on the glove model, and here on the patient. But you have to be aware and to control this tip, otherwise you might hurt or do injury to the mucosal ureteral mucosa. I think it is the best way to remove a double stent, and we no longer use forceps for this task. Like I told you in my introduction, you have to be humble and listen to all the advices, even from nurse or from someone less expert than you. So this is one of the techniques that had changed my life on percutaneous renal surgery. So my first steps of PCNL were in 2097, and I had only the hydrolytic lithotrieter, and it was very difficult to remove all the small fragments, and also I didn't have all this experience. And my scrub nurse told me, you know, the nephroscope is hollow with the working channel, and it is similar to an aspiration cannula. So why not use it like this? So we have done it. The suction tube is adapted to the nephroscope operating channel, and it is the best way to extract all the clots in the first introduction of the nephroscope. Small fragments less than 5 centimeters are extracted through the nephroscope operating channel. Larger ones are attracted through the implant sheath. And I think it is the best way for matrix stones. We can remove large matrix stones in few minutes. Can we take a recess time? So I want to talk to you about guitar. Do you know how this metal band or this rock band have their sound, distorted sound, fat distorted sound? They are using stomp boxes. Here is the sound of a regular guitar. Distortion effect, and here with the distortion effect. And here with the distortion effect. So I look up some schematic on the net, and I scavenged some parts from those economic bulbs, light bulb, and I put it in a sardine can. I have no previous experience on electronics. And the regular fuzz are from $100 to $150 or $200. And mine with scavenged part is less than $1. So why am I telling you this? We are urologists, not guitarists. So can we transpose this process to our electronic devices, camera, electrosurgery unit? So I look up on the net and I found the schematics of this electrosurgery unit. So we can do the same for people that cannot afford to have this. Also for camera, I told you about Bantuk in the the introduction. So in 2018, Dr. John Lazarus from South Africa was a winner, and with his idea, wireless endoscopic camera that cost about $120 or $40. So he had used this platform that called the Raspberry, which cost Raspberry P0, it cost $27 or $26, and you can add the wireless component and the camera. So it costs less than 100 and about $120 or $40. We can do the same. We can have more idea. We can extend them. We also had one of the urologist group in public hospital I was helping had their hand ballistic handle broke, so they cannot afford to buy it. It was about the cheapest one was $1,500. So we made one less than $100 by a metal worker, and it is working very fine. Why not do the same by dissecting this ballistic generator, and I'm sure that it will be easy to reproduce. I was helping friend doing PCNL in this large stone staghorn, and we had this remaining stone in the upper calyx. We tried to remove it by suction or by irrigation, and no way. So we needed a basket, but we didn't have one. Nitinol basket. We didn't have a flexible nephroscope, and we didn't want to do another percutaneous access to push the stone with the needle or something like this. So we had this floppy hydrophilic guide wire, and we had the idea to weave it as a basket. So it was inserted through a WG pusher through the nephroscope, but we cannot extract it through the nephroscope. So the whole nephroscope is moved with the basket. Here in the patient, insertion, progression until reach the calyx, and we were lucky. The stone was catched by this makeshift basket. And it was extracted. So, like I told you, we have to push the idea forward. So we began to think how to do it. Can we use another thing or material existing in the operating room? Monofilament suture, a nylon, polypropylene, something like this, fishing line. So we tried with the nylon basket. So a basket is weaved from a nylon suture 2-0. This is coaxial WG pusher. So the suture was inserted into it, and by moving the inner part, the basket can be opened or closed. And here in our glove model, and it worked just fine. We have done it in few patients, but this is just for the people that we cannot use it regularly, but we can make it better. So this is through the nephroscope, but it is very large for the rigid ureteroscope. Can we do it? So can we use a less than 3 French ureteral catheter, or use it with the guide wire? But how to fix it with the guide wire? So we took this PTFU guide wire, and to fix it, we have to break between the loops of the outer coating of the guide wire, and here it is. We can move it through the rigid ureteroscope, and the rigid ureteroscope is used as of course it is backloaded through the rigid ureteroscope, and the outer sheet of the basket will be the ureteroscope. Here in our glove model, exploration, the stones are found, then with the basket. So the basket is closed by fixing the stone against the tip of the rigid ureteroscope. We can use the same thing through the flexible nephroscope or cystoscope. In our glove model, and if we can do a smaller knot, we can use it also through the flexible ureteroscope. So if you have an idea, please send it to me through my email. So the fishing lines are mostly nylon, so we can do the same with fishing lines. So if we look for an alternative to guide wire, what can we use as a guide wire? So a friend had asked his secretary to buy him a fishing line to train for weaving basket, like I showed you. But she brought a very large diameter fishing line, about 8 millimeter. And so he called me and he said that he found an alternative to guide wire. So here is the fishing line. The guide wire is inserted over this fishing line, but it is not, it is radiolucent. We can use it as safety guide wire, through and through guide wire. Also, sometimes we use a long vascular dilation balloon, longer than our guide wires, and we use it for this. So we can also make a three-prong forceps from a double G pusher. Its tip is opened to 3 pieces. And the outer sheet is made from the coil housing the guide wire, which is 12 French, and the double G pusher is 8 French. So the forceps and the outer sheet is shaped like with the handle. Here with the handle like a real 3-pronged forceps, and here in the attracting a stone. So I will show you a magic trick. We have G-tip guide wire, and we want to insert it through the needle or through the catheter, but we need both hands to do it. And even with the introducer, we still need both hands. So is it possible to do it single-handed and without the introducer? Here is the magical part. So with just one hand, the guide wire is straightened and inserted. So how we do it? So by attracting over the guide wire, we attract over the inner core, and the outer coils of the guide wire are made straight by fixing them between index and finger. With one hand, the other fingers do the attraction, and the guide wire is made straight like this. So we have this large outflow during PCNL, and we don't have a spare rubber seal. So what will you do? So we had a very bad vision. So we took the rubber head of syringe bag, of syringe piston, and we took small fragment or patch, and we patch our rubber seal, and it worked just fine. No more outflow. Alternatively, we can use the whole rubber seal, rubber head of syringe, especially in large nephroscope. This is 20 milliliter syringe, and now with the friend in the public hospital, he is always using this tip. Also, in a flexible, we don't have those fancy ureteroscope seal, and they are expensive, about $20 to $30. So we take the injection port of serum bag. So the basket is introduced, is backloaded over the puncturing needle. So now we don't have no outflow. Also, the movement of the basket are limited, so it gives some protection to the movement of the basket or the laser fiber. So if we don't have an adapter of ureteral catheter to serum drainage bag, we can insert it directly over the puncture needle into the last end of the Foley catheter. So we have just one bag for both catheter. Alternatively, we can use the injection port of serum bag. Also, at the end of PCNL, we can remove this soft rubber valve, and it fits just fine over the ureteral catheter and the drainage bag. I need an endoscopic electrode. So I was doing a workshop in a patient with the UPGO, and we wanted to do a nodopuloplasty, which is a nodopulotomy and transversal suture through the unique percutaneous tract. But we have this travelet vision, and the exploration of the parenchymal tunnel found these active bleedings. So we decided to do a parenchymal tunnel cauterization just to show for the participant of the workshop that it is feasible. We could have just inserted the amplitude and weight. So we didn't have an endoscopic electrode. So what to do? So we have this ureteral catheter with steel membrane sealant, and also with this large brass knob. And by applying the handle of the electrocauteris unit to the stylet, we can do cauterization. So here the endoscopic view, and especially with monopolar cauterization, you have just to touch nicely, not without pushing, without much pressure. So this is before the coagulation and cauterization, and at the end of the procedure we have a nice view. We use this ureteral catheter to do incision in the bladder neck here. Also retrograde endopulotomy or antegrade endopulotomy, coagulation during an endopulotomy. Sometimes even the ureteral catheter that we have don't have steel membrane stylet. So what is the alternative? We have this bleeding and we do a coagulation. We can use a basket with small tip to do cauterization. Through the flexible, we cannot insert, through the flexible ureteroscope, we cannot insert ureteral catheter. So to do coagulation or incision, a small peeling of the tip of hydrophilic guide wire. So here on this endoscopic view, this is a small retrograde endopulotomy with the flexible uteroscope using a guide wire as electrode. Here's small cauterization. One of the tips and hacks for optimization of what we have at hand is equipment multi-use. So I already told you about using the rigid ureteroscope as a second or third tract. And we have a progression in the retroperitoneum here without any protection. So now we are using a drinking straw as access sheet for mini PCNL with the rigid ureteroscope. So this is drinking straw of 13 or 14 French. It is inserted over a dilator and inserted over a guide wire. Introduction of the rigid ureteroscope, and here extraction of small stones. So this is an alternative if you are doing PCNL, you don't have a small nephroscope and you cannot afford to have one. So for regular access, we use the regular nephroscope, 20 French nephroscope, and for smaller one, we are doing this mini PCNL with the rigid ureteroscope. So here, using the nephroscope from undergrad PCNL for this large stones of the kidney and the ureter, and also from below with the retrograde ureteroscopy. Here we have a complication with the stone migration in the pleura, and it was used as a thoracoscope and extraction of the stone. Here is the lung and here is the pleura. Also, we have done a small series of retrovesical hydrated cyst and renal hydrated cyst, also with the nephroscope, and the puncture through the bladder and the extraction of the hydrated material. Here we had used the nephroscope to do retroperitoneoscopy, nephrolysis, and percutaneous nephropexy. And also we had used it as laparoscope, bladder lithotracing, for retroperitoneal abscess, as colonoscope in 2 or 3 cases during percutaneous colon injury. So George Bernard Shaw has said that progress is impossible without change. And if we cannot change our mind, we cannot progress, and we cannot change anything. So my conclusion is to provide a non-stressful supervised teaching and learning for people, and for each one of us have to have a large knowledge of techniques and tips and tricks for economic use of equipment to overcome difficult situations. We have to cultivate these idea, tips and tricks, and especially we have to share them. And we have to do or build and maintain a network of people we can question about support, and we have to share this idea. We have the opportunity to have social media. And I conclude by quoting Bob Marley from, he said, "Emancipate yourselves from mental slavery, none but ourselves can free our minds." And I thank you. We have more tips and tricks in my YouTube channel, and here is my email. So thank you very much.
Good afternoon. I'm Manuel Gerard Sevilla, the Vice President of the PUA Mindanao chapter. On behalf of the organizer of this event and the Philippine Urological Association Mindanao chapter, I would like to express my sincere gratitude to all of you who participated in this PUA Mindanao postgraduate course online on urology. This event wouldn't have happened without the people who organized, spearheaded, gave talks, and sponsored today's event. And because of this, I would like to extend my gratitude and congratulate Dr. Nimrod Firaza, who spearheaded this event, and Dr. Rodrigo Hipol III, our chapter president, and our only sponsor, ECE Pharmaceutical Incorporated. This is the first ever postgraduate course we held online, especially during this time in pandemic. And as such, we must congratulate and pat ourselves on our back for making it a successful one. In this online course, we were able to learn from our distinguished speakers and hear their insights, particularly on COVID, as well as the different subspecialty of urology, pediatric urology, urologic oncology, female urology, endourology, male infertility, and practicing urology remotely. I hope that you have learned much from them as much as we have, and that you may use this knowledge in your practice. Because you were able to hold this postgraduate course online, probably in the future we may be able to simultaneously do this postgraduate course both on online and on site. Here in the Philippine Urological Association Mindanao chapter, it is our mission to be able to share our knowledge and update our colleagues about urology in order to increase awareness and in order to preserve everyone's health, especially in this time of COVID. Thus, it is with great care and love that we are doing this for all of you. Again, I thank everyone for participating in our online course, and I wish all of you the best. See you next time in our online course. Keep safe and God bless.